Please, those of you who are here, get to listen to this next fabulous panel on time. Welcome back. Hope you had good conversations at lunch. This next panel is, will be moderated by my colleague Shelley Weissman, and we'll be talking about drug courts and best practices of ensuring access to medications to treat opioid use disorder in drug courts, but we'll also be talking about other specialty courts and general courts as well. So Shelley, please take it away.
Great, thank you. So I'm Shelley Weissman. I'm the Associate Director of the Addiction and Public Policy Project at O'Neill, housed at Georgetown. And I'm also a person in recovery. So I've been, oh, thank you. So for the last over 20 years. And I was thinking this morning as I lay in bed at like 5 o'clock in the morning, thinking about this panel that, before I came into recovery, and to me it's kind of funny now, but it probably was not very funny at the time. So I came into recovery after a series of events, one of which involved an arrest in the town in Texas where I was living. And at the time of this arrest, my mom, I was a teenager, my mom was dating the chief of police of the town. And it was, fortunate or unfortunate for me. Many struggles later, I found recovery, and, I found out actually years later that it was actually my mother that had orchestrated that arrest. It is funny now, but, when you think, it is, I think, because, it was part of my story and my journey, and I ended up, working in programs and going to law school and working, doing a lot of really great stuff that recovery kind of opened up for me. But at the time, that was all she knew how to do. Like, that was the way that she knew how to help me, was to get me arrested. And I think that we've come a long way in 20 plus years, but have we come really that much further than that? There are many communities where families and parents and people who are in the lives of people that use drugs, they don't know what to do. They don't know how to help their loved ones, and people don't know where to get help themselves. And so, when I think about the kind of purpose of this event, you have these really, I want to say kind of innovations, things that communities are starting to do to meet this need of, how do we help people? And we've started thinking at O'Neill about, what are the key intervention points where people might be able to access help just a little bit easier. And right now, a lot of those intervention points are in the criminal justice system. And, when I think about, my kind of personal history and my work in the field, law enforcement and courts, there really is a tremendous opportunity to help people if there is the right understanding, the right leadership, the right tools. And, I just wanted to take a moment to commend the people that are here today, particularly from the judiciary, from the law enforcement community, because, we talked about this in the last panel, that for a long time, people were told, there are a lot of different systems that thought, oh, this is not my job. And a lot of people ended up in the criminal justice system. A lot of people ended up in places where people may or may not have known what to do, and started thinking outside the box. And the people on this panel today, and Judge Hannah also, who was not able to make it in person, but is going to be Skyping in. Oh, there he is. Hi, Judge Hannah. This is just, I love this. This pleases me. When I think about like a future state of what our systems could be and look like, I think about the people on this panel, and their bios are in the folders and online, and so I'm not going to kind of get into reading each one of them, but I want to kind of introduce people and talk a little bit about the work that they're doing before they kind of, go into their spiel. And I'll start with Judge Hanna. I actually met Judge Hanna when I was working for the governor in New York. I went to Buffalo to visit the opioid treatment court that Judge Hanna championed. And I sat in on the court, and I know you'll talk more about it, and also went to Judge Russell's Veterans Treatment Court, and I was completely blown away. I spent the first part of my legal career as an attorney representing people in a variety of different areas, but one of those places was housing court in Brooklyn, which is maybe not what hell must be like. I'm sorry to say, it's difficult to navigate, it's very challenging, it's very adversarial, and nobody, it's not kind of, geared towards like helping people generally. And I went to these courtrooms in Buffalo, and you saw people who were ready to help someone find housing, people who were ready to help someone find a job, peers who had been through what that person was going through. And Judge Hanna, who was speaking to people, as an equal. And that is not something that I had ever seen before. It like totally blew me away. And so I'm so glad that Judge Hanna is able to join this panel today, and I know he'll talk more about his work. And David Lucas, who I recently connected with, who works at the Center for Court Innovation, which is an organization I know well, who is doing tremendous work innovating the court system. I went to a community court that the Center for Court Innovation had launched in the neighborhood of Red Hook in Brooklyn. And you had, I was totally blown away by this. There were signs pointing people where to go, which if anyone's ever spent time in courthouses, it's really confusing. And you had someone from Medicaid there, someone from the Human Resources Administration, which is, helps people get public assistance. All the courts that you needed to go to were in the same building. And these are things that we would think are common sense, or we would think are things, well, why don't we already do them? But we don't. There's a lot of work to do in our court system to connect people with the help that they need. And Taylor Robbie, or TK as I call him, I met TK, when I was living in Albany, and he's a tremendous peer advocate, speaker, innovator and inspirer, I will say. And he's somebody that was one of my first calls when I got this job, because TK's been through drug court, been through jail, and we talk a lot about how can we as people who are in recovery but also in positions where we can influence policy, what can we do? What's our vision of a better world? So I'm so glad that you're here. And Chief Justice Rush of the Indiana Supreme Court, I met Chief Justice Rush when she was coming to speak on about a project that they've been working on related to educating the judiciary about addiction and substance use disorders, and what is the role of a judge, and how can judges be more involved and engaged? How can legal services attorneys be more involved and engaged? Because the reality is we need all hands on deck for this thing. And we are in very fractured and siloed systems even now. And so I'm very excited to hear about the latest projects that this wonderful task force is going to be launching very soon, but I won't steal your thunder away. So I'll have each person talk for maybe 8 to 10 minutes about your work and your thoughts and your experiences, and then we'll ask some questions, and then we'll open it up to the audience. So maybe we'll start with Justice Hanna, or Judge Hanna.
Oh, good afternoon. Can everyone hear me? All right. Again, I'd like to thank Ms. Weissman and Neal Institute for the invitation, and I'd like to apologize for not being there today. I was actually called by my chief judge to present on the panel this morning, and as probably people that work for Judge Rush, if your chief judge asks you to do something, you kind of drop everything and make sure it's happening. But I'd like to thank the IB staff or the IT staff to make sure I can participate. I just want to commend everyone that's there. I actually want to commend Ms. Weissman because I too am in recovery. So I want to say God bless you and keep doing what you're doing. And most importantly is that, and I'm glad we started with this, we have to break down the shame and stigma of addiction. A lot of times people are dying because they are afraid to go out and ask for help. And I think that's the crux of why our court was started. Our court was started because people were not making it to treatment. Our drug courts were started back in the 90s, but with the opiate intervention court was started because of the introduction of fentanyl and carfentanil. Individuals were not making it to their court dates. So what we do, and I'm glad you gave a good introduction, is that we take down all the barriers from recovery. I kind of liken it to being like a Baptist preacher. When our individuals come in front of us, they'll give me 15 reasons why they can't try recovery. No housing, no transportation, no Medicaid, no funding, no ancillary services. We try to take away all the barriers so all they can do is focus on getting better. And I think that's our job, is to make sure we focus on them getting better. Most importantly, we have day-to-day, daily face contact with our clients. And we do call them clients, and we all know why. I don't want to bore everyone, because we have to instill hope and respect in our individuals. And I'm going to start with that before I get into our spiel about our court, is that most of our clients have burned every meaningful adult contact that they have. Shelly said in the beginning too, a lot of people have, let's say, burnt all their bridges. I always say people don't catch buses to commit crimes. They always commit crimes around people that they love and they support. And once that love and support is not there, some of our clients lose hope. So our job basically with our daily face-to-face contact is to make sure that they have positive adult contact every day. We get involved in almost every part of their life. And some of our clients say, well, they'd rather go back to jail. But I tell them that's not the option. Our job is to make sure they get better, because the second we place our hands on them, we want to make sure they walk out of our courtroom bearing to come in. Our court is a judicial triage program, as we like to call it. We place our clients in medically assisted treatment within hours of their arrest. To use the brand names, we use Suboxone, Vivitrol, Methadone. We get our clients linked to the services that best fit them and get them linked within hours of their arrest. All of you might have heard horror stories about people waiting 4, 5, 6, 8 weeks trying to get into a medically assisted treatment program. And you know no one is going to come back 3 weeks from now if you tell them today is their day. So what we do is break down that barrier, give them the nice warm handoff from the sheriff to us to treatment, and then we take away all the other barriers to make sure that their path to be successful. Another thing that we do is we suspend their criminal charges. We suspend, we don't dismiss. I'll say it again, we suspend, we don't dismiss. From the onset, we make sure the first thing we're doing is focusing on the whole person and making sure they get better. They can face their charges at the end. So I always say, whether you like CNN or Fox News, you're going to love our program, because the charges are not getting dismissed. The person is getting better, and that's what we do. We linked it with ancillary services, and people say, what are ancillary services? Driver's license. I don't know about in your jurisdiction. Buffalo is a city roughly about 500,000 people. Maybe the general metropolitan area has a 1.5 million, but you can't get around in Buffalo unless you have a car. There is rapid transportation, but if you don't have a car, you can't get to work, you can't get to treatment, you can't get back and forth to your appointment. So that's why we focus on them getting driver's license, and we provide actually bus tokens and transportation so they get back and forth to their appointment so they don't have that bar. Also, we want to link them with a peer support. And I'm glad TK is here today, because they can't do this alone. They cannot do this alone. It's easy for a guy in a suit and glasses to tell someone like, yeah, you can do this. You know, all you got to do is come to treatment, go to court, go to work, be home at a certain time. But when someone that they can see that been through it and that can talk to them in a way that myself and maybe Judge Rush can't, because we have judicial ethics, because sometimes you really need to put someone in a headlock and let them know that these guys are really trying for you. And all you have to do is try yourself. Even when people use, in our court, we do not sanction or punish use. We sanction and punish behavior. And the reason why I say that, and our clients are in the throes of addiction. I'll use myself as an example. I'm not supposed to eat meat at all, you know. I eat red meat probably once or twice a week. And my doctor told me he's going to put me on medicine. And if he said if I keep not listening to him one day, he might tell me he's going to have to cut my foot off. But what do? I have to see him in a couple months. I'm on a vegetable-based diet now. I'm drinking water 4 or 5 times a day. And when I see him, I want to mask the fact that I have a problem. And that is a problem. See, it's another addiction. I'm glad I used that as the analogy. Our clients want to do better. Some of them may need to do better, and they may know they need to do better. But because it's an illness, they can have everything set in front of them and they may stumble or fall. But our job is not to punish them, it's to give them the tools and assistance to do better. I always say this, and again, I can brag about this program, but it's not really for me to brag about. I want to brag about the success of our clients, and I know we all talk about it. The best thing is on day one, our client is not the same person that they're on day 150. They don't even look like the same person. They don't talk like the same person. And they want to give me all the credit when I didn't do anything. They deserve all the credit for the success. They made all the sacrifices. And I know I'm preaching to the choir, but I always like to give this analogy. They say on a scale of 1 to 10, 10 being the best experience in your life, 5 might be graduating from law school, 8 being married, 10 depending on how great your marriage is, 10 the birth of your child. What does people think your first shot of dope is on a scale of 1 to 10? A lot of people may say 8, 10, maybe above 10, but I'm going to tell you, your first shot of dope on a scale of 1 to 10, and 10 being the most pleasurable experience of your life, is a 5,000, meaning it's 500 times better than the greatest experience of your life. And that's what we're dealing with. You can't sanction someone because they're using. You have to give them the tools to be successful. They can have everything that they want in their whole nature to say they weren't going to use because this thing has such a pull on them. You have to make sure you're mindful of that. And I'm glad Chief Justice Rush is here because that is our job. It's not just to educate our clients, it's to educate the people that look like us in the judiciary. Because a lot of people get old-fashioned, you know. They hear that old-fashioned saying about let's be tough on crime, let's be tough on drugs. But I'm telling you, these are our people. They're our friends, they're our cousins, they're our nieces, they're our nephews. And some of us, if we have the, I guess, the guts to admit it, it's ourselves. And you have to make sure that person is armed with the tools to be successful, especially when they walk in. Another good thing about our program, what I like, and they did tell us to give takeaways, we have a curfew. And you say, how do you have a curfew for an adult? Some of you may be too young for this, but there was a song in the 80s by this group called Houdini. It was called The Freaks Come Out at Night. And I don't want any of my clients running into any of these freaks, you know. I know a lot of us are getting too grown and they realize that we don't get in trouble anymore, but I want our clients' day to be regimented. And I think that's what keeps us all out of trouble. You get up, you go to work, you do what you're supposed to, you go to treatment, you go to your recovery support groups, and at the end of the day, like the rest of us, they're exhausted and they go to sleep. Our job is to give them the habits and the tools to be successful. And I think it's been very rewarding and successful. Again, I can talk for an hour without taking a breath, so I'm going to close and then on 2 points, and then obviously we're opening up for questions again. I would say the most important part about this is getting people to link to treatment immediately. We have an embarrassment of riches, but I think this can be done in every community. We did community mapping to see all the agencies that were supporting everything that we do. We made sure that the community, that we have a treatment agency here, a treatment agency here, maybe an ancillary support group or a family navigator support group here. We brought all of them together, so when individuals come to our court, like when Ms. Weissman was there, you walk in there and it sounds kind of odd, but you get service for your addiction if you get arrested immediately. And I know you hear horror stories about our clients who have been trying for 6 or 8 or 9 months, and then they get arrested, and then today they have all their answers solved. A Medicaid ombudsman talks to them so they can get insurance. Someone drives them back and forth to their appointment. They get transitional housing. But that became because of the community mapping and the community partners and the relationships that we have with our community partners. And because of which, and I know Judge Rush is going to talk about this, the judge being the convener, and I don't want to steal her thunder, Once you do that as a judge or a law enforcement officer, or even as an administrator in a university, being a convener, you bring all the groups together and they bring and provide the services, and then you can work synergistically. And now when our clients walk in, I guarantee you they walk out of that courtroom 100 times better than they first walk in. I'll stop here from now, and then of course we'll be here for questions. And again, I want to thank you for your attention, and thank the O'Neill Institute for having a conversation on this very important topic.
Oh, thank you, Judge Hanna. And, I just wanted to say a couple things to your point of, link to treatment immediately. In Judge Hanna's court and in the Buffalo court, there's a van outside of the courthouse that connects people to buprenorphine immediately, basically, and they used with some federal dollars. The program in Judge Hanna's court was used with, a few $100,000 federal dollars. It's not multi-million-dollar reform. It's bringing people together to do what needs to be done, and people want to help. There's an organization in Buffalo called Save the Michaels, which was started by two parents who lost their son, Michael, to to this disease. And this organization has family members and volunteers that literally picks people up at the court and drives them to treatment. And so, there are people that want to help. There are people that, want to get connected into these efforts in every community. So thank you, Judge Hanna. So our next panelist is Chief Justice Rush. And I'm very excited to hear from you about kind of the big picture of the judiciary and efforts that you guys are working on.
Wonderful. So this is sort of just a view from the bench. I'm Chief Justice of Indiana, and I'm also the chair, one of the co-chairs of the National Judicial Opioid Task Force. And they asked me to do that about 2.5 years ago. And they said, do you think the judiciary should have a national task force? And I said, yes, you should have done it a couple years ago. They go, great, we're going to have you chair it. So, at that point I said, well, certainly there's some resource I can go to, right? There's this place where I can find all the evidence base, and there's a program, we'll get it done. Well, there wasn't. So you really had to say what's our lane and what's not our lane, and then how do we collaborate across the lanes and get that done. So we know that it's a crisis, but here's some facts that really jumped out at me. I know the Surgeon General, he's from Indiana, and Dr. Adams has been a wonderful resource with regard to connecting us to the medical community, because this really is the intersection of law and medicine, like no other crisis that I've seen. So 96% of the cases in the country are filed in the state courts. The criminal justice system is a primary referral source to get people to treatment other than self. That's shocking, right? And people with opioid use disorder are 13 more times more likely to be involved in the criminal justice system. So it's like, damn, we better get it right. I swore because I thought I'd say I'd jump that, I'd just get that right out there. So it's like, so what do we know what we're doing? Well, there was a lot of work to be done. We had courts that say, I'm a Vivitrol court. I go, you are? Based on what? Or a legislator would call and say, there's this new oxygen therapy out there that you really need to look at. We know what we know, and we don't know science, or we wouldn't be sitting there as judges on the bench. So those three statistics sort of scare you to your foundation when you're a judge. We have 1.3 million cases filed in Indiana. When you look at the number of state court, there's tens of thousands of state court judges across the country. Here's our role. We give consequences, we work at cutting the supply. We want to support children and families. And now with this crisis, it's saving lives as much. We know how to be tough on drugs. We just don't know how to be smart. So how do we start training judges? And it's not just judges, like probation is under the courts in Indiana. You've got prosecutors and public defenders. You've got a whole system of people that touch on these individuals that are coming before us. So if we're a primary referral source and there's no go-to place that we can get what's evidence-based, because every judge will tell you, I only order evidence-based. Well, who's going to say, I only like non-evidence-based? Right. In my court, where do we go and get that information? So really the thing for us is, how do we get the entire judicial branch, if the cases are before us and we're the primary referral source, how do we get to be smart on drugs? Chief justices are involved with, we set the education for all the judges in our state. So there are a lot of levers we can pull as chief justices. So I like what Judge Hanna said. Judges can bring people together. If you call, I set up an opioid summit in Indiana. All 92 counties came. They brought their sheriff. They brought their community mental health provider, the judge there, the prosecutor. They brought teams to really train on, because again, I agree with the panel earlier, these local community solutions really are important. You know the tools you have, and how do you get them there? So a lot of judges will say, well, I'm a civil court judge, so I don't need to understand addictions. And I say, no, that's not true. Look at all the dockets that are affected. There's almost not a docket that we have in the United States that's not affected by drugs. Some judges tell me I can't be a problem solver. I don't need to have a problem solving court. All my cases have drugs, whether it's a guardianship. We have an unusual amount of grandparents raising their grandchildren right now. And think about this epidemic. Where's that next generation of grandparents going to come? Because we're losing a generation. Who's going to raise the next set unless we get this done? I agree that with housing court, I went to housing court one morning just in Marion County. I work in Indianapolis, 275 evictions one morning. Substance abuse is throughout it. And think about a trauma in a child's life, losing their housing, and not one of those people were represented by an attorney. And I kept saying, you have defenses, warranty of habitability, for those lawyers that are out there right now. So you have that. Then you've got, for judges, we also do attorney discipline and judicial discipline, and we're seeing more and more people in our profession really getting in the throes of addiction. We had you probably saw in the news, there's a North Carolina judge died of opioid overdose last week. I've been to 2 funerals of friends of mine that are judges whose children died of heroin. So you've got to set up a system. So this is the basic premise of the task force. It's essential for judges to have the best information of the causes and effects of addiction and the best practices for treatment. We have a report that we're going to be announcing. We have a toolkit at a website. We have about 30 different bench cards and tools, and you may have to school your judge. If you have a judge that says, I don't agree with Matt, go to the Conference of Chief Justices, National Center for State Courts. Just put that in opioids. Put courts and opioids, and you'll see the Resource Center. We talk about the ADA implications to not allowing Matt. So if the Conference of Chief Justices have adopted best practices, and we've worked with the doctors, and I got to give a lot of credit to HHS and to Johns Hopkins and Susan Weinstein, who's out there, that was on our, did a lot of work, and just getting medical legal experts together to say, what are the ramifications if you don't? For judges, you have a lot of pregnant women in your court, and a lot of times they say, well, I had to keep her in jail because she just keep using, what about the baby? So when is MAT? There is an evidence-based practice with regard to MAT for pregnant women, and there's also some real science with regard to when MAT can be used for adolescents. So we're getting that out. So all judges and justice professionals, and that's probation, that's all the way through the spectrum. Here's the bottom line, things that we are training, and we've got bench cards on our website, and our national report will be launched at the National Press Club here in DC on November 20th, and the Surgeon General will be there and the Drug Czar will be there, because again, it's public health and law intersecting. So there, you can read that. I'm not going to read that, but this is, we think, every judge that works with children need to understand MAT for pregnant women, reasonable efforts finding, the high quality and frequent visitation. What we do is we have so many babies, NAS babies right now, and in the welfare system, that's a cause for immediate removal at birth, but we're looking at that and the outcomes for those children when they're not able to be with their mother can be poor. So when can we have a child safely be with the mother? And we're looking at ramping up family recovery courts. Best practices just came out last week to have problem-solving courts in the child welfare. We will be, that will probably be hitting our website within the next week. In Indiana, we've gone from 6 family recovery courts that are, I'm hoping to have a couple dozen by the end of the year, because I think it's very important both for the parent and for the child. While the mother goes through recovery, if you can safely keep the children with the parent while they're going through recovery, I think we can have tremendous outcomes and reduce trauma for children significantly. So we had the task force. We've been working for the last 2.5 years, and this is the Addiction Resource Center for you. Nothing's copyrighted. It can be printed. You're looking at anytime you touch the justice system with regard to somebody, I mean, even if you're a doctor saying, what do you mean your judge won't let you be on medication-based treatment? go school your judge, or call me, because I've had to call a lot of judges based on that. And I'm not afraid of making that call. So these are some of the tools. So they're broken out. We have prenatal substance exposure, improving outcomes for women and infants. And see that, if you can see that it's blue, everything is a hyperlink and it's a bench card that you can get. If you want a hard copy of it, the State Justice Institute is subsidizing those. We will get you one. It's just email me. It's my contact information. Is my contact information in the? It's loretta.rush@courts.in.gov, and we'll get it to you. Trauma, substance use, and justice involving children. The court's role in child welfare, and really we did a lot of work with regard to the impact on children, and then the children, and I'm kind of flying through these, but they all are there. Understanding the basics of addiction, and really it's, it's like, what, for dummies, like, Apple on that, it's for judges, understanding the basis of addiction. What is addiction? It's a chronic treatable disease. And 2 weeks ago in Indiana, we trained all 600 of our trial court judges. We had a doctor there talk about the neuroscience of addiction. And I'm not saying the judges love being in there, and I'm sure some of my evaluations will come, but you've got to understand the science of addiction to know what type of treatment it is. And we learn new areas. I learned EPA, we learned patent. We're capable of learning enough so that we can make better decisions with regard to the people that come before us. The treatment of opioid disorder, again, that has medication-assisted treatment. It talks about the difference between Suboxone, buprenorphine, and methadone. A lot of judges have been burned by methadone with regard to selling and abusing, and you've really got to get to the basics of addiction for them to understand that this was part of the disease, and it's part of. If the information we have, if you have a 5% chance recovering from a heroin addiction, if you don't have medication-based treatment, why would we not all go for medication-based treatment? Then we've got courthouses that have fentanyl. How do you deal with it in your courtroom if you've got it as evidence if one of your employees touches it? We have bench cards for how to deal with that. The fundamentals of screening and assessment. And then we've done a lot with our rural communities, talking about telehealth, we're talking about telecourts, and how do we get treatment to the rural communities. And throughout all these bench cards are examples of programs that are working. Why don't we learn from what's working in different communities? So that's there as well. So we've got, here's the last one, collaboration education, working extensively with our tribal communities. And how do we have a sample template transfer agreement for somebody to get from state court into a tribal wellness court. We've also got transfer agreements to get somebody from federal court into a state problem-solving court. You think about a veteran that's in the federal system that wouldn't have access to the same level of justice as they would have in that. So we have that. We have an SUD dictionary for courts, and words matter. We got to attack this stigma, and judges, we've got to talk about this different with the people that come before us. We have a bench card with telling them what words to use instead of others, and that is also on the website. We as a state came up with an action plan a year ago, and we've sort of stuck to it. So in the materials, and I'm sure the PowerPoints are going to be available, Stephanie, later, that this is what we came up in Indiana. And then one of the last things I want to talk about is the sequential intercept mapping system. Judge Hanna talked about those warm handoffs. We have done training. We have taken local communities, judges, sheriffs, mental health providers, prosecutors, county councilmen, mayors, and we've done trainings on the intercepts. And I thought when we brought this together that all our people would be interested in intercept 2 and 3, the justice system. Nope, they were all interested in intercept 0. How do we, at the time of the first getting into the system, have services in our community so that they don't get deep end? We are deep end by the time you get to court. How do we convene as judges and look at the resources in our community and really bump up what we have at intercept 0 and 1? So we've had some wonderful training, and then we were able to, with each county that did the training, give them a grant of $120,000 to start that SIM. The Legal Service Corporation Opioid Task Force report is just a fantastic document, because you think about somebody with addictions in the criminal justice, you don't think of when somebody gets to recovery, they don't have their license, they need to have expungement, they've got civil debt. I mean, there's so much to deal with, and you don't have that right to an attorney on those matters that you do in your criminal case. So wonderful examples, and just 2 things. The medical legal partnerships, and I know there's some docs out there. these things are fantastic. It's really embedding and working with the medical community and embedding attorneys or civil legal aid attorneys in medical facilities to be able to, you think about a homeless vet coming in. As a doctor, you can deal with the physical health, but you can't deal with the civil legal needs. So we're trying to pair them together on that. I'll skip over that. And then the final thing, we are partnering with SAMHSA, the American Academy of Addiction Psychiatry, the Opioid Response Network, the National Judicial College, and the National Judicial Opioid. We're having a national training. We're sending doctor and judge from every state to kind of train the trainer, and we will have a product that we're working on, which is a medical legal resource guide. So where do you go for that information for the treatment? I mean, you are looking at methamphetamine. We're seeing just a rash of methamphetamine right now. So this will be released later this year, and then we're having these judges that are going to get trained to come back and train justice professionals back in their state. So this guide will be available. And I talked really fast to get through that, so and then I'm flying out at 4, so don't ask me any questions after this.
Well, thank you, Chief Justice Rush. This is, I started my career as a legal services attorney, and I'll say a guide like that would have been very helpful, because people work in their little silos and are not always aware of the resources or kind of the big picture. And I think, for the most part, people mean well and want to help, and to give them easy to access tools like that is huge, game changing. All right, so next up is TK to talk about your thoughts and experiences on this topic.
All right, so thank you guys for having me. I'm going to try to breeze through this because I could talk about this literally forever and I won't shut up, and I would like to go at some point too. So my name is Taylor TK Robbie. I'm the peer specialist for a crisis diversion program called The Living Room. It's like a mental health urgent care for people with substance use disorder and mental health. So it's like an alternative to going to the ER for people who aren't necessarily at that level and need some bridged interim services provided for them. And most importantly, I'm a person in recovery. And for me, thank you. That means that it's been over 4 years since I've had a drink or a drug, and I'm also in recovery for mental health as well. And so just a brief overview of how my use started. My use started back when I was in high school and I was 13 years old. That's when my use started. And it started off as, like we all hear, in that simple pathway of alcohol and marijuana. And as the years went by and as my addiction progressed, then eventually it led to me finding heroin. And heroin, like it was stated before, like people really become addicted to heroin. And I know that I did because it was like the love of my life. The very first moment that I did it, I was in love with it because it did what I was looking for. It numbed my thoughts and my feelings, and I didn't have to deal with the things that I didn't want to deal with, especially being someone with diagnoses like bipolar disorder and anxiety and depression. That numbing feeling was something so great for me. I was like, okay, I don't have to have a care in the world anymore. So because of that and a lot of other factors, my use progressed for a lot of years, up until January 15th of 2015. So I was with this kid who I used to use with, and we were going to pick up, and as we were leaving from where we were picking up, I had crashed my car into a fence. And it was this very slow, quick sort of thing that happened, and before I knew it, my car was surrounded by 3 cop cars, and before I knew it, I was handcuffed in the back of the cop car. And that whole time, I remember in that exact moment, my hand was bleeding all over the back of the cop car because I was trying to get my car stuck off the fence, and the only thing I was thinking about was not that, hey, I have to call my mom and tell her I'm going to jail, or not even the fact that I'm going to jail. I was pissed off because I didn't get to use my drugs, and that was the biggest thing on my mind. And so when I ended up going to jail, so I'm originally from Sullivan County, New York, which is this very in the middle of nowhere place in New York State that I'm not even sure really exists, to be honest. And so when I was in the jail, when I was in the holding cell in the jail, one of the hard parts was obviously my addiction had progressed to the point where I was going through active withdrawals. And so while I was in the holding cell, there was no Suboxone, there was no methadone, no nothing. So I was going through withdrawals, sitting in the jail cell for 2 days waiting for the judge to come in to finally read me my charges. And then eventually they transferred me to the county jail. And even once I got into the county jail, it took like an additional 2 days for me to finally get prescribed Suboxone. And one of the interesting things that I thought about it, and it kind of shows you, how stigma plays such a big part in the substance use disorder crisis in general, is that when I was meeting and I was talking to the CEOs, like begging like for Suboxone to help me through these withdrawals, like they couldn't believe that I used heroin. And because especially in that area, it was like all automatically assumed that a young black male isn't someone who's going to be your typical candidate for using heroin and being addicted to opioids. That's like a disease for the young white kids. And so the kid who I actually got arrested with, he got his Suboxone a lot faster than I did, and I had to like literally advocate for myself to be able to get Suboxone while I was in the jail because they did not believe that I was a person who was actually addicted to opioids. And so they gave me, a prescription for Suboxone, but they only gave it to me for 5 days. I got it for 5 days, and then there was nothing left. So then for the remainder of the time that I was in jail, there was no Suboxone for me to have. And I think a big piece that people forget about is the fact that, yes, Suboxone helps with, the withdrawal symptoms, but there's also the mental component of the craving. So just because like my withdrawals aren't as severe, there's still that mental component that I'm now dealing with because of the cravings. So after, I had my court date and I got bailed out of jail, there was no like aftercare for me while I was waiting for everything. I had to like search for treatment for myself, and it took me about a month after I got out of jail to find treatment and to be able to get prescribed Suboxone. And I'll never like forget, like people, if you've never, had a substance use disorder, like it's hard to imagine, but like while I was sitting in my house, at this point my car was impounded, I had no car and no way of getting any sort of substance. So having substance use disorder, it's like there's this little voice that's in your head that's constantly like chattering in your ear. So I'm sitting in my bedroom, the same bedroom that I used in every single day of my life, with this voice in my head telling me, you need to use. And I felt like I was literally going crazy and using my mind, that I was on the verge of a mental breakdown because there was nothing to relieve this anxiety and pressure that I was feeling. So I called my dad on the phone. I just started like sobbing because I could not deal with it. And eventually we found an outpatient clinic that was able to prescribe Suboxone for me. And like once I got on Suboxone, it helped me tremendously because one of the big things is like once you stop using drugs, it's like all of those things that you stuffed down for so many years of your life, all of those things all come back up. And so the Suboxone was this tool that could help me at least manage in the beginning to get myself stable so that way I can continue to work on the other things that I needed to work on. So as I got out of jail, I was thankfully given drug court, and it was this weird situation because I was arrested in Sullivan County, but I was in Schenectady County drug court. They were supervising my case because I moved to Schenectady County because I knew if I went back to Sullivan County, I was gonna relapse and I was gonna die. And like for once in my life, I didn't want to die, and I wanted to do something different with my life. So while I was in drug court, it's very interesting to see that dynamic that goes on between, the coordinators and the participants. There's like stigma on both ends. And I think that's a big barrier that we're facing because the participants in their minds, and after experiencing it, I can see for good reason, they think that I'm gonna go to drug court and they're gonna send me to jail. So I can't trust these people to help me with the things that I need to get help with. And then on the coordinator side, they're thinking people get generalized. stigmatized. So they're like, well, I've met with people and I've worked with people who had substance use disorder before, and this is what they did, so this is what you're going to do, and so we have to treat you like every last person that we've had come into the courtroom. And so there's this disconnect where there's no sort of rehabilitation that could ever happen, because we're all like at each other's throats ready to wage war with each other because no one trusts each other. And that was like a really difficult process, and that's really difficult to go through for at least a year, especially when you're someone who has like 15 plus years on your head, to be in a place where you feel like you can't trust the person who's, you know, your life is in their hands. That's really difficult. And so I was on Suboxone while I was in drug court, and one of the biggest problems that I had was, you know, for myself, I felt like I was at the point in my recovery where I was stable enough to navigate my recovery on my own without the use of Suboxone anymore. But in drug court, they didn't think that I could do it. And they would not, like, I had to fight to, like, allow them to let me stop taking Suboxone, because they were telling me, no, you have to stay on it for the remainder of your stay while you're in drug court. And I think that's where, again, this stigma and this generalization, I think things don't become individualized as they should be. For some people, you know, if they need to be on Suboxone for the rest of their life because they feel like that's what's going to work for them, I feel like they have the right to do that. And if someone wants to be on it for 2 months and then decides that, you know what, that's good for me, they have that right to do that too. And I think playing God, like with people's fates and telling them what they can and can't do, or not allowing them access to that, is like, should be criminal, you know? And so eventually I got off Suboxone, and they allowed me to do it because, like, my lawyer, like, yelled at them, and I have the best lawyer, and I love her for that, you know? And being on this other end now, like, working with, you know, people who are still going through that drug court process, it's really interesting to see, because now I have a client who I was just working with, and so she was remanded to prison. She tried to do everything she could to not go to jail, but they remanded her to prison. And so while she was in the process of getting sent to prison, one of the biggest problems that we had was continuing her prescription for Suboxone that she had on the outside. It was easy for her to get, like, her Lexapro and her Zoloft and all these other medications, but when it came to Suboxone, they did not want her to be prescribed the Suboxone, like, going into jail. And I think that's, like, the most asinine thing I've ever heard, because they're one and the same. There's, like, this disorder that's going on in your brain that's causing a lot of havoc in your life. So to tell someone, okay, it's fine for you to take your medications for your depression and for your anxiety, but we're not going to allow you to take this medication that's going to help with your substance use disorder, I think that's kind of crazy, you know? And I see too often working in this field that we separate things, and it's either one or the other instead of treating them in tandem. And everyone's, like, fighting for funding, and everyone's fighting to, you know, it's like, yeah, I can't, because I'll go on a tangent, so let me stop there. So, you know, but I really hope, like, at the end of the day, that we're able to get to this state where everyone's able to be on the same page. And I think that there's a lack of education on the coordinator's side and on the people who are participants in drug court. And so I think the more that we can educate and talk with them about, like, the realities of it, the better off that everyone can be. And we have to end stigma, because it's gonna literally, stigma has killed people. So we need to get it together and try to end it as best as we possibly can. So that's my spiel. I'll shut up now and we'll go on.
Thank you, TK. All right, David, you're up.
Skip to the first one. Okay, thank you for sharing that, TK, and I think it dovetails nicely with where I'm hopefully about to go. Good afternoon, everyone. I'm honored to be participating today and humbled by the level of expertise in this room. So thank you to the O'Neill Institute for including me. My name is David Lucas, and I'm from the Center for Court Innovation, a justice reform nonprofit based in New York, and I'm a technical assistance provider for drug courts across the country. Prior to this, I was a treatment lead in a drug court up in Canada for about a decade and a harm reduction volunteer by night with Toronto's overdose prevention site. So if you're trying to find my accent, it's like Fargo, but more north because I'm actually from Winnipeg. So yeah. So I'm sorry for that. I'm going to be speaking today about some of the ways that MAT has been taken up and not taken up in the drug court space. And I think it's important to note that even if a drug court says yes to MAT, the story doesn't end there. How it's rolled out can really impact how it's used, who uses it, and who doesn't. So, and I'm also a social worker, so it's also going to get a bit social worky in here. Big ups to the other social workers. I know there's 2 others at least. So with that in mind, I want to set out 3 core themes, and these are by no means the only important puzzle pieces, but they're important largely for their hidden impact. And the first is equity and inclusion. First of all, expanding low barrier access to MAT is a racial justice issue. But in the drug court space, I think we need to acknowledge this even more so. Why is that? At present, drug courts have an equity and inclusion problem, and I should say that this is not a controversial statement. NADCP themselves said across the U.S., African Americans and Hispanics are underrepresented in treatment courts relative to the prison population. American University similarly noted that disparities exist in access to treatment court programs, completion rates, and recidivism outcomes. It's so pronounced that both organizations have created specialized toolkits to try and remedy these disparities. So here we are, we have drug courts, a more humane legal remedy designed to treat rather than imprison people with addiction. An alternative to incarceration strategy, yet access to this remedy has made its way disproportionately less to communities of color. Similarly, and as we've heard, the rapid expansion of MAT as one of the key responses to this public health crisis is a story of uneven access across racial lines. TK just gave an example of that. For example, more white people, especially in suburban areas, have had access to private, insured, office-based buprenorphine, whereas more black and brown people in low-income urban settings rely on methadone clinics. And as we know, methadone clinics typically have more apparatus for monitoring its patients and making their drug use more public and visible to authorities. So we have these 2 strategies, drug courts and MAT, that in some ways have medicalized addiction for some, protected it for some, and kept it more criminalized and exposed it for others. The urgency we have today, then, to solve these crises of addiction and despair that is tied to thousands of deaths will not by accident undo the racism baked into our justice and healthcare solutions. So I would urge us today to not only think about science and messaging and legislation, but also pay close attention to the subtle technologies of whiteness that have been built into these 2 responses. The second is diversion. And I don't mean diversion courts, I mean diversion of MAT medications. And this is worthy of attention, not so much because the act itself, but how we talk about diversion. And folks, the stigma here is real. This is, I think, maybe the worst one. We still have a long way to go on this one. When diversion is discussed in the drug court context, it is at best considered an issue of broken trust between the client and program. That is to say, the participant is lying and should probably be sanctioned. At worst, it's considered a criminal act worthy of a more serious sanction, sometimes even jail. So just quickly, I want to urge those of us coming from a criminal justice background to stay familiar with the research on this or talk to people who use drugs. Diversion is most often an act of mutual aid to help another person going through withdrawal. It can also be a form of self-medication to help deal with one's own symptoms, or to address problems with affordability or pharmacy hours, perhaps most importantly, as a protective factor against overdose. Many people use OAT because they don't want to use fentanyl. People don't divert MAT to push the limits of their high. They do it to get unsick, to avoid using street supply, and to not overdose. The research, and that's not necessarily true 100% of the time, but the research tells us that's the majority in both prisons and community. This research also tells us that most MAT is not sold, it's actually given away. So if you work on the front lines or you know people who use drugs or are in recovery from opioid use disorder, talk to them about this. So if diversion is rampant in your drug court with your clients, clinicians, and OTPs, to strengthen the therapeutic rapport and service quality. Diversion is mostly a survival mechanism, meaning that sanctions and mistrust aren't going to fix anything. And the last kind of narrative or discourse I think that's still kind of coloring this conversation in the drug court space is Big Pharma. I think we can all agree that this has probably been a little overused to explain the current crisis, maybe a lot overused. No doubt it played a role, especially in non-urban, sparsely populated, white and recently unemployed parts of the country, but it is not the whole story. Addiction and overdose will, sadly and unnecessarily, survive the rise and fall of the Sackler family. But I raise it here in the drug court context because I've seen how it's had the effect of creating a culture of mistrust with health providers, with medication in general, and really perpetuated the idea that abstinence, true abstinence, the safest, the freest, the most rewarding kind, does not include opioid-based medications like methadone or buprenorphine. So the remedy here is to understand that healthcare providers are an essential part of a drug court's continuum of care, not opinions to be invoked occasionally to settle legal questions about a participant and their treatment plan. In my opinion, the future of drug courts involves incorporating a dedicated doctor or medical director into the fold for the sake of additional oversight. To me, this would effectively enshrine a continuum of care model that includes medical expertise in a key drug court decision-making process. We did this up in Toronto, Universal Healthcare, that kind of helped. But we did this up in Toronto, and it was hugely positive. So here's some additional barriers, and I'm not going to go through all of these because I don't think we have a ton of time. But I want to, again, focus on just a few which I think are a bit more hidden, but just as impactful. Drug courts rely on phase systems, meaning that participants must hit certain benchmarks in order to progress through the program and either earn or retain certain freedoms. Through this system, participants are incentivized to complete a cycle of treatment or get a job or get a car, get housing in order to demonstrate that they're building stability into their lives. In and of itself, there's no problem with these incentives, but it's important for the purposes of our conversation about MAT that MAT can actually become a stick in the spokes for everything I just mentioned. Not all of the treatment or housing providers that partner with drug courts will accept those using OAT, and many jobs available to people with records don't necessarily align with pharmacy hours. This means that the need to progress through these programs at a prescribed pace could indirectly deter clients from considering addiction medicines. The second column here I'm calling micro-practices because I want to highlight how diffuse our responsibility is to encourage participants to use addiction medicines if desired or indicated. From judges to probation to addiction counselors, what kinds of things are we saying or doing every day in drug courts that might indirectly deter participants from wanting to use MAT? Are we publicly celebrating when participants taper off MAT? Are we pushing participants to attend 12-step meetings without knowing whether or not that meeting is accepting of addiction medicine? Are we adding new layers of surveillance and monitoring more urine screens onto clients using MAT? Are we sanctioning clients for missing MAT doses, treating them differently if they want to taper off? Are the personal beliefs that we have about one medication versus another coloring this conversation? For example, we see a lot of Vivitrol-only courts. And are we pushing clients to attend treatment that doesn't allow MAT or encouraging them to taper ahead of attending? There's a lot, and I mean, some of these could be life or death situations, especially the use of jail sanctions, for example. We've kind of covered that today, but this is still a really common issue for a lot of drug courts who if you call them in this kind of like TA context that I often have these calls, they say, oh, there's definitely an overuse of jail sanctions in my state. What else is going on? Oh, well, we don't have a lot of MAT. Oh, we also have a lot of overdose. And it's crazy to hear that they're still using jail as a sanction in this context. Also, are we inadvertently pushing anti-medication platforms? Are we offhandedly disparaging other psychotropic medications and treatment in other settings? And lastly, and perhaps without realizing it, are we prioritizing a definition of recovery based on complete abstinence over a broader promotion of health, safety, and recovery in all of its forms, including MAT? So I'm going to end there because I want to leave some room for discussion, but I've created a 15 recommendations for drug courts for both MAT integration and overdose prevention, asterisk harm reduction for drug courts. If anybody's interested, hit me up and I can pass that along to you. Thanks.
Great, thank you. All right, so I'm going to ask a couple of questions, and then we'll open it up to the audience. I think we have about 10 minutes left. Okay, so. No, that was great, and thank you, everybody. I guess kind of one opening question, Justice Rush, you talked about, there are judges who, have had bad experiences with methadone, and they don't, people's personal viewpoints kind of coloring their decisions. TK, you talked about having to wait and then having to wait again to get the medication that you needed, and then how the pendulum kind of swung the other way about how you couldn't get off of it when you wanted to. And, David, you talked a lot about the barriers, the ones that are obvious and some of the ones that aren't. And, we've definitely seen this across the board and kind of varying widely in drug treatment courts. Should there be a mandate? I mean, what is the role of the other branches of government? I've posed this to the panel to, identify these challenges that might be harming people or in some cases killing people. Should there be, like some states have required in statute, drug courts to make MAT or medications for opioid use disorder available and not kind of condition drug court participation on whether or not somebody's on medication. So I don't know, Chief Justice, if you can start with
I'll
that.
start with that. I think the power of the dollar sum. I know that the National Association of Drug Court Professionals, if you get a drug court grant, you can't say no to MAT. But I think the bigger issue is really it's the individualized treatment that if two people are addicted to heroin do not need the same treatment. And like for you, my question when you were saying is, well, if your doctor said you could get off the Suboxone and then there was a plan for it, why is the judge telling you that you can't? So I think educating them on the idea of individualized treatment, we just don't know what it's going to look like, because now MAT applies to, or now they don't want us to call it MAT now, they want us to call it medication-based treatment. It doesn't apply to methamphetamine, but I know that they're looking at that. But it used to be if we had somebody with addiction issue during I was a judge when crack cocaine, and shame on us that we didn't set up an addiction model at that point, but you would have this cookie cutter approach in the courts. You do acute, right? You detox, you do acute, you do an IOP, you do a 12-step program, you were done. Everybody kind of fit in that box. So the more that we learn that the best practices and the tools that we are training judges on, it's individualized treatment, and we're going to have to trust the doctors with regard to, yes, they can wean off, no, they need a higher dosage. We cannot be substituting medical judgment. And that's why the medical legal partnerships are so important, because I think then you get both voices at the same time. I don't know how many states have legislation for MAT. Do you? Does anybody know?
5 or 6.
2, okay.
I think a few more.
So, I mean, we're setting this out. We're setting this out that you've got some legal ramifications. Again, grant dependent on it. There's ADA cases going now against jails and courts that have not allowed MAT. And then your judicial leadership has got to train and make some difficult phone calls with that, because most of the drug courts are dependent on grants, and I think that has to be a string that the dollars follow the fact that if you have a drug court, then you're going to have to appreciate the individualized treatment and can't have a prohibition.
Other thoughts?
I think you hit the nail on the head with the individualized treatment, and I think because that's like the biggest problem is that no one gets individualized. And there's always even like within people in the community, they say, oh, well, I know this person who used Suboxone or was on methadone and they were nodding out the whole time. Or I know this person who used Suboxone and they were prescribed it and they began selling it to people. So once there's like that one person who comes in who does something that's not necessarily good, in our eyes, then everyone gets treated that same way. And so no one's really able to thrive after that. And I think I think someone was talking about earlier before is the aftercare portion is even as that's going on, making sure that there's the aftercare set up, because even if they're in the treatments and they graduate from drug court, we need to make sure that once they leave the court that there's still something in place, because the MAT or MAR, whatever you want to call it, can only help but so much, but we need to make sure that they're linked with these resources, because that's a small portion of the problem.
Yeah, and I'll just quickly add that I think a little bit of extra oversight would be good. Drug courts rely on an incentive and sanction model, and I think drug courts could maybe be subjected to something maybe named differently, but where if they were, really lagging on getting caught up with the services that they deliver, that they should maybe not be able to ask so much of their participants, especially if they're suffering from opioid use disorder. So I think there's ways to kind of pull people along a little bit more forcefully, because it is a matter of life and death. But I'll also say, TK, I'm glad you brought up aftercare, because I think this is a huge thing. I mean, we could just do a conference on what aftercare means and what recovery communities mean. Maybe one on housing, because as was mentioned this morning, we've got, meth is on its way, and we're going to need housing that accommodates people in all forms and all stages of recovery. And this goes way beyond opioids, and it goes way beyond the day you graduate from drug courts as well. So I take that point.
And Shelley, if I can admit, there's no perfect process, and there's no perfect recovery. And so we treat our clients the level that they are, kind of like what TK and Judge Rush said, and divine a plan and a system that works best for them. And I think the crux of it is education. We have to educate our friends and our colleagues to know that this is medication. Is if someone takes medication for high blood pressure or cholesterol or anything to live a more successful and productive life. And this is a necessary medication for our clients to live a productive life.
Okay. So we have about 5 minutes left. I wanted to make sure that we had an opportunity for questions from the audience. Come up to the microphone, please.
Hello.
Hello.
My name's Tracy Gardner. I'm from Legal Action Center. I'm glad to see Dr. Hanna. I will admit that when I first read about an opioid court, I wanted to punch somebody in the head. It really didn't play well. And actually, I talked to a couple of lawyers. I am not a lawyer, I just hang out with them. But there was one lawyer who thought that that might be somehow discriminatory. I understand the imperative, right? We're talking about people at risk for overdose, particularly around opiates. But it does, the kinder, softer approach still, I could say, hurts or itches or galls. And I appreciate that Judge Rush said, shame on us, that we didn't do something during the crack era, but I don't think there was any will to do so. We are having this whole conversation. Someone mentioned it earlier that we really need to understand the right people became affected. And so we made public policy changes in record time when it did not take us record time to get here. So I just need to say that because that was definitely my first impression, what does a crack court look like? But I know that there are problem-solving courts, mental health and for alcohol, but what is a crystal meth court going to look like? And it still takes us back to what we need to do more holistically. And then again, I will whine and complain that I wish there were more health people at this conference, because when health people talk about opioid use disorder, they're going to stick to where they're comfortable, which is, the clinical side and the compliance of patients and the best places for practitioners to be able to, and they need to be here because they're complicit in this. I insist that they should be coming to your court, Judge Rush. They should be coming to your court, Judge Hanna. Not that you have to pull them in. Their behind should have been there a long time ago, and they need to come and be, how can I help? Much more enthusiastically than they are. And again, I bring up the incentive of money because putting money, a price on the heads of people who are in life and death struggle seems to cut through the BS in ways that we haven't done yet.
If I can add on to that, I think it's much more deeper than that. I say it almost every place I go that, and I'm glad Judge Rush said it too. It's a shame what we did to our soldiers in the 70s and 80s when they came back from Vietnam, when we locked them up and didn't give them the hope and the respect that they needed. It was a shame what we did to the black and brown brothers in the 80s and 90s during the crack epidemic. And I liken it that we learn from our mistakes of our past. And I say it everywhere I go that we learn from that and we're committed to make sure we don't make that same mistake, especially when people need help. And I'm glad that question was brought up today because that is the elephant in the room. It's like when people used to smoke on airplanes, you know. I think the science, as Judge Rush said, has caught up to this. It's a medical problem. In the 70s and 80s, it wasn't viewed that way. And now it's viewed as a medical problem. And the questioner is right. Maybe the right institution or the right era, the right demographic has brought it to a head. But since it's brought to a head, we're going to make sure our citizens, and especially our participants and clients, get the help and resources that are needed.
I just want to thank the panel. My name is Lippy Roy. I'm an internal medicine, addiction medicine physician. First and foremost, TK, thank you for sharing your story of recovery, the struggles, the discrimination. I mean, it's appalling. You should not have waited for the Suboxone and the medications, but thank you for sharing your story. That's how change happens, and congratulations on your recovery. Thank you, both justices. I also want to, you were all mentioning this very appropriately, treatment needs to be tailored. So when I treat patients with hypertension or diabetes, I don't just all of them give them lisinopril, or all of them give them metoprolol. And there's a reason, there's guidance, there's guidelines, there's data guiding my clinical decision making. Same thing with addiction, regardless of what the substance use disorder is. The treatment needs to be tailored to the individual. By the way, people should not have to be tapered off their buprenorphine. It's a conversation I'm always having with patients. At the same time, if they don't need it, they don't need it, right? If the cravings no longer are there, they don't need it. So it goes back to having individual conversations. This goes back to what Tracy was saying. And both justices were saying, I firmly agree in collaborating with my judicial colleagues in whatever information I can share. And similarly, you certainly filled the many gaps in my knowledge. It wasn't until I started working for New York City jails and Rikers that I started interacting with prosecutors, public defenders, and judges, and offering trainings, and we can certainly learn from one another. I will say, when I gave a talk at the John Jay College of Criminal Justice, this was a few years ago, and there was a gentleman, an older gentleman, a black man, who was saying, you know, it's all fine and well that you guys are talking about addiction as a public health problem, but where were you people in the 80s? And when my community, my relatives were dying, and my flip answer could have been, well, in the 80s I was in high school, but no, I recognize when I stand there on a podium, I represent an entire profession. And so I said, you're absolutely right, sir, and on behalf of the medical profession, we apologize, and we're trying to learn from our mistakes as we go forward. And I think my impression is that the criminal justice system is also kind of acknowledging that, and we just need to work together. So thank you all for your expertise.
Thank you. All right, our time is up. I want to thank the panelists. Thank you, Judge Hannah from Buffalo, and thank you all so much. All right.
Take away my role, my line. So we have a networking break now until 3 o'clock, at which time we'll discuss child welfare policy. Thank you. everyone to take a seat. This is our last panel of the day. So for the final panel of the day, we are going to discuss addiction and child welfare policy, providing healthier outcomes for families. And we have just some wonderful speakers. Mary Lou Leary, who previously worked at the Office of National Drug Control Policy, is going to be the moderator. Elizabeth Bricco, who is a writer from the Pacific Northwest, will be discussing child welfare policies and her personal experience. Laura Radel, who's with HHS's Office of the Assistant Secretary for Planning and Evaluation, has done quite a bit of research in this area, so she will also be speaking, as well as Dr. Mishka Turplin, who is an OBGYN and addiction medicine doc. And then last but not least, Nancy Young, Dr. Nancy Young, who's the Executive Director of Children and Family Futures, who is an advisor to our initiative, and as I like to say repeatedly, is one of the few people in this country who really operates at the nexus of child welfare and substance use, a very important and discussion that we're going to have. So Mary Lou, I'll let you start. Thanks.
Thank you for sticking around, everybody. Personally, I'm just really interested in what these panelists have to say. It's just one of the most pressing issues, I think, in this whole sphere of substance use disorder. Personally, I have about 35 years in federal service and in the nonprofit sector, many years at the Justice Department, but then at the end of my career, I was lucky enough to work with Regina and Michael Botticelli at the Office of National Drug Control Policy. And now, since this is Washington, and I was in the White House in 2016, so obviously I'm no longer working for the government. This is Washington, I'm a consultant. So today we're going to talk about addiction and child welfare policy. And, you know, you often hear people say that substance use disorder affects so many more people than just the individual user. It affects their loved ones, their families, their whole communities. And that's really at the heart of what we're going to be talking about today. What about those families? What happens to them? And in particular, what about the youngest ones? What about the children? The children whose families are impacted by substance use disorder. What happens to them and what happens to their structure, their support system, their loved ones, and what they've always known? You know, the real question is, how do these families survive and how do these children thrive? You can look at the scope of the problem, and we have data. Of course, we have data on everything from between 1999 and 2014, because our data is always outdated. There were the pregnant women with opioid use disorder coming into hospitals to deliver quadrupled in that period of time. And then from 2012 to 2016, just 4 years, the number of kids in foster care rose 10% across the board, and in some states it rose 50%. Just overwhelmed the system. So it's obvious we need to rethink, reshape our responses and our policies. And the panelists who are here with us today are the people who are really on the front lines of reshaping that approach, reshaping the policies, and in Elizabeth's case, living firsthand with the results of the policies that have actually been in effect. Elizabeth Bricco is a writer from Pacific Northwest, as Regina said. She's now living in Broward County, Florida, where she is fighting to regain custody of her 2 children. So you will hear her own compelling firsthand experience in this arena. And Laura really is an amazing social science analyst at HHS in the Office of the Assistant Secretary for Planning and Evaluation. She focuses on substance use disorder and child welfare policies. Dr. Turpin Mishka is a senior physician research scientist at the Friends Research Institute. And he's very unusual in the sense that he is board certified in gynecology, obstetrics, and addiction medicine. So he kind of has the whole package there. And Dr. Nancy Young is, as Gina said, the Executive Director of Child and Family Futures. That's a California-based research and policy institute. And she really works on improving outcomes for children and families who are affected by trauma, by substance use disorders, and by mental health disorders. So we've got it all: research, policy, treatment, and fighting on the ground for custody of children. We're really pleased with this panel. And we will start with you, Nancy.
I think
Elizabeth is starting.
Oh, I'm sorry,
first, because I
Elizabeth.
think, oh, my PowerPoint is up.
You're right. That's why I thought you were starting.
I like Mary Lou coming over here because I can see it a little bit better. Thank you all for sticking around to the afternoon, and thanks for the invitation to be here. I think the theme that we've been hearing throughout the panels today is reflected in this still siloed after all these years. Although we've been talking about a lot about collaboration and what we need to do to put these systems together, that we still have these effects of different training, different funding systems, different ways in which we allow people to publish in which journals. So when we try and put pieces together, there are a lot of barriers to what we think about when we think about family recovery, that says that it's not just the parents, but that the children also have in their own right the need to have interventions, prevention, and sometimes treatment. So this idea that each member in the family means that we need to have multiple partners across these systems. So I was thinking, well, we should just talk about, well, what do we know? So I think others on the panel will talk about some of the issues, and I thought I'd do a real high level, what do we know? And first, starting with, what do we know about the data? These are listed by states, the prevalence that they report to the federal government about the number and the percent of parents coming into the system who have a substance use problem. So either alcohol or drugs a contributing factor. So when we think about, well, overall it's 37%, and you probably see that data, that indicator all the time. But when you know that, for example, these states are contiguous, New Hampshire and Maine. New Hampshire reports hardly any parents with an alcohol or drug problem as a factor in the case, and Maine reports about 60%. So there's something else going on besides the prevalence of alcohol or drugs in their community. Some of the things that we know is that the variable in these data system is not a required data system. We don't have standardized ways in which we try and determine which parent needs help with a substance use disorder. The timing of when those questions are asked, perhaps the worker doesn't know till well into the case that this is a factor that needs to be recorded in the case. And if it is that, then it's just really not easy in some of the antiquated data systems to get it and then mark the file. So why the undercounts and why that variability across states? We think we know a little bit about how to help communities do a better job of even identifying who are the parents that need help. I couldn't resist, if any of you saw the Sesame Street announcement about 2 weeks ago about their new character who is a child of a parent with a substance use disorder. And shortly thereafter, Naomi Riley wrote an op-ed in the LA Times that says, even within these single states, when you look at the numbers, they look fishy. If we want to see a decline in the numbers of kids removed from their homes and placed in foster care, it pays to follow the time-honored Sesame Street lesson. be honest, and learn to count. I think that graph I just showed is an indicator about some problems that we have across the country in policy about learning to count. Now, this is how we at Children and Family Futures are putting together sort of our knowledge base and our technical assistance when we're working with states or communities, and that's very complicated, I know, so I'm going to break it down a little bit. This first row are the kinds of practices that communities put in place when they have to begin to start working across systems to identify, to engage parents, to make sure that children have the interventions that they need, that the recovery supports are in place, that the kinds of monitoring that needs to happen to make sure that parents are able to get the services that are in their case plan. All of those are like this practice changes that we know from various federal grant programs and lots of evaluations that have been done in the last 25 years, that this is what people do sort of first. We also recognize that there's a whole set of system supports that have to be in place to sustain that practice of working across systems when we put whole families together. And we have and that includes the training, the budgeting, some of the things like the information system, some of the things that I mentioned previously. We have a little bit of a discussion going on in our office that is communication its own systems element, or is it so important across all of these practice and policy arenas that it should be diagrammed in a different way, it should be called out in a different way? Because without the specific communication protocol, we know these systems don't communicate, they don't work together. So this idea of a very specific communication protocol becomes key. And all the way back to the Adoption and Safe Families Act, we've talked about in putting those practices together, this conflict in the timing. The Adoption and Safe Families Act, 12 months for a permanent plan, 15 months out of 22, and unless it's not in the best interest of the child, that social services is to file for termination of parental rights, which is completely often in conflict with a chronic disease that we often think about, particularly in early stages, as one day at a time. So these conflicting timelines, we've learned some things about over this, again, last 15 or so years. And this is that row, that's the kind of the standard process of a child welfare case. And what we know is that those practices make a difference about what the timing is. And in fact, in the Sobriety Treatment and Recovery Team program, they have data about the outcomes, as well as some of the other 4A waivers that have been put in place that have looked at the timing of this. So when we work with communities, we say it's not okay to just do those practices. It's about when you put them in place for a family. If a family isn't getting screened or assessed for a substance use disorder until after the disposition hearing, it's way too late. So we talk a lot about timing matters, and how you rearrange staff sometimes isn't a new cost. It's about how you rearrange staff to make that timing happen. We also know in one of those practices that increased management of the recovery services and monitoring of compliance is very important. We've learned that in a variety of places. A recent publication that's available is about recovery support specialists and the different models that operate in family treatment courts and in child welfare offices. So I wanted to make sure that you had that resource, because if we simply give a parent a piece of paper that says, go get treatment, here's a list of phone numbers, what do y'all think happens? Doesn't happen. It's this recovery support and the engagement that needs to happen so that there's hope that can be seen and hope that can be put in place for that parent to be able to engage. Another thing that we know about the monitoring comes from the family treatment courts, and a recent meta-analysis of 16 evaluations said that families that participated in a family treatment court were 2 times more likely to reunify than families receiving conventional services. So if you're an attorney in the room and you work in the child welfare system, are all of your parents getting access to these enhanced services? what's reasonable efforts? Is that a lever to use in this policy arena to make sure that all parents have access to the services that they need? And it was mentioned earlier today about the Family Treatment Court standards just came out within the last short period of time. I listed them, and there's the website is there where you can get the full copy of that. So how does that all come together? We like to refer to the outcomes as the 5 R's. Recovery, the number of children that remain at home, those that reunify, repeat maltreatment, which is where we've seen in multiple evaluations where the big bang for the buck comes in. It may not necessarily be in the length of time in out-of-home care, but it's definitely in the lower rates of repeat maltreatment when families have access to these comprehensive services and reentry to foster care. So I look forward to the discussion and any questions that you may have.
Thank you, Nancy. I could see that a lot of those themes that Nancy was talking about are actually encapsulated in the report that the O'Neill Center did with the recommendations for changes to be made in the child welfare system. So thanks. Elizabeth, we'll hear from you next.
Hi. So my name is Elizabeth Brico. I'm a writer and a journalist fellow with Talk Poverty, as well as a Reimagining Communities fellow with the National Council for Incarcerated and Formerly Incarcerated Women and Girls. It's a very long name, but they're very cool people. I'm also a person who is diagnosed with PTSD and opioid use disorder, and I'm a mother. So today, that's mostly what I'm going to be talking about, is what it's like to be a mother during what I refer to as 21st century prohibition. And on that note, I think maybe the most important thing I could say today is to just remind everyone here that most, if not all, of the issues that we're discussing today would not even exist if drugs were not illegal. That pause was to change the slide, but thank you. So my daughters have been separated from me since April 13th of 2018, which is a very long time for me to be separated from 2 very young girls. They're 4 and 5 now. They were 2 and 4 when this began. When we were separated, there was a very convoluted case that involved various weird accusations, but mostly centered on an accusation of drug use. But once I gave them the various body parts that they wanted from me, my hair and my pee and all of that, they decided that they weren't going to focus on that since that was all negative, and instead just kind of talk about the fact that I had this diagnosis and that I had a history of drug treatment and that I have PTSD, and go by that. At my trial, the investigator, who was testifying against me, mind you, admitted that my children showed no signs of abuse or neglect and appeared very well bonded to me and to their father. My in-laws admitted that there was also an abandonment claim where they kind of said that I had been away for 3 days and they didn't know where I was. They admitted that actually they'd been on the phone with me the whole time and really did know where I was and how to contact me, and it was really just me going away for a couple days while they watched their grandkids. That didn't matter. In the end, the judge ruled against me, and these are her words, not mine. She said that because I have great skill with language, I could sell ice to an Eskimo. So basically, because I'm a writer and I know how to speak, I'm lying. And also that because I had admitted that I had at one point spoken to my brother-in-law about the possibility of maybe buying marijuana, that meant that having an opioid use disorder and considering buying marijuana is bad coping skills and somehow also bad parenting. So I just wanted to share these facts of my case to highlight what is really going on inside of these courtrooms. For these really absurd reasons, my daughters have been separated from me for over a year. And this is something that is really happening right now to me, and not just to me. I speak every day to parents around the country who are dealing with very similar circumstances, just really absurd accusations. Maybe they did go and use drugs outside of the home one night and somehow got caught, and then their kids were taken away. Things that really did not involve actual instances of maltreatment are being called maltreatment, and children are being ripped from their homes, put into foster care or put into kinship care with family members, and parents are being forced to go through these hoops that oftentimes make no sense. In my documents that I was given to I guess, understand what the issue was, why my children were being taken from me. It said the mother neglected the minor children, and the acts of neglect include that the mother neglected the minor children. Now, I mean, I don't know, maybe I'm not an expert. I have a couple of degrees in English and writing, but to me, that doesn't mean anything. I don't know what that means. And if there was something wrong that I had done as a mother, that some behavior that I in fact need to correct, I don't know what it is. No one has given me a template for correcting that because that's what they wrote. It means nothing at all. So I did appeal my case because I thought it was absurd that I was ruled against in the first place. It was denied with no opinion, so the judges that denied my appeal didn't give me any reason for denying it. But in the appeal documents, I read that the opposition's argument was essentially that they didn't need to wait for maltreatment to occur. I have PTSD, I have an opioid use disorder diagnosis. Who cares if it has that in remission tag on it? Whatever. They don't need to wait. Something bad is going to happen because of who I am and what disorders my brain has. So they're going to take the kids. They don't need to wait. That's a picture of me and my daughters in Seattle. And I have some pictures of us just to kind of show you my family, but I've chose that one in particular because this case is in Broward County, Florida, where I had very recently moved, where my husband's family lives, to help him with the health crisis that he was dealing with. But if we were still in Seattle, if I had never left, this case would not exist. I would still have my daughters with me. I'm not going to go into all of the reasons I know that because I don't really have the time, but they handle things differently, and I'm not saying they handle things perfectly, but they handle things differently there, and I know that I would still have my daughters with me with this case, because this case probably wouldn't even have gone to court in Seattle in the first place. And I think that that is a huge fault with our child welfare system in the way that we handle parents who use drugs and who have substance use disorders, because there is no unity between states or even sometimes jurisdictions. It's not right that a parent should have her rights to her children terminated forever in one jurisdiction because of that judge's opinion or the laws in that one jurisdiction when they would not be upheld in a different jurisdiction. This is the United States of America. We should have some kind of uniform system or some kind of oversight that stops this from happening, but this is a very, very constant reality. So this is just kind of to contextualize like where my story fits in with other people's. There are over 3 million children who and their families who are subject to child welfare investigations every year. That doesn't mean they're all going to be substantiated, but these are people who are being intervened on by child services. At least 2/3, not necessarily, and I know we saw the removal statistics earlier that were different, but at least 2/3 of open maltreatment cases involve some kind of parental substance use. Many of the experts that I've spoken with while doing my work as a journalist believe that it's higher, but because of data collection issues, that's kind of where they're at right now. So this is a really important issue. It's something that the majority of families that deal with these cases are dealing with, and that doesn't necessarily mean that 2/3 of parents are addicted to drugs or using drugs in a chaotic manner. Maybe they just use them once in a while, and that's another important differentiation that we need to make, because a lot of times we're sending parents to treatment because they get caught with a substance in their urine, say, and that doesn't mean that they need treatment. Maybe they were just using something one night. And we need to accept that that's something that people do, and that doesn't mean that they're bad parents or bad people. So I can't talk too much about the algorithms because I don't have the time, but I mentioned earlier that I've been researching these algorithms that are being used in some places around the country to make determinations for child welfare. And in every single one that I've looked at, substance use disorder treatment has been a criteria in those algorithms that are used to kind of give some of them are used to give risk factors to individual families, and some are used to kind of just determine general risk factors among that population. Substance use disorder treatment is always being used as a criteria in those algorithms. I think it's really important to note substance use disorder treatment. So the people who are seeking treatment are getting this on their record, and that's being used in a sense against them. Whereas people who aren't seeking treatment, maybe if they don't get caught with drugs, if there's no reason to know about it, then they're not going to be included in these algorithms. It's not going to be used against them. So this is de-incentivizing people to seek treatment, because who wants to have that used against them? And I'll also note, in my case in particular, the investigator in my case who first filed a shelter petition to have my kids taken, at no point ever before filing that petition ever contacted me or attempted to contact me. at any point, and in court she admitted that and stated that the reason that she filed the petition without speaking with me was because I had a history of going to methadone treatment. That's us again. So this is the status of my current case. It's currently on an adoption track. So they're trying to move to have my children adopted, probably by my in-laws. And the reason for that has been due to a bunch of very complex factors. One of the biggest one has been that the judge really doesn't like my biochemistry. Apparently I have low creatinine levels compared to the general public. So she's continuously saying that my negative drug screens are actually positive because my creatinine levels are low. So they're trying to make this argument that I'm diluting like every urine test I ever take, and these are observed urine tests. My income has never been counted at any point during my case, even though I have income, because my caseworker is continuously being changed. I think I'm on the 4th one now. I could be wrong, it might be the 5th, but my caseworker has continuously been changed, and every single time that's happened, the new caseworker has wanted a different kind of document, because I'm a freelance journalist, so I don't have like an average pay stub that I can turn in. So they've wanted a different kind of document to prove that I have money coming in, and then suddenly, because there's a new caseworker, that past document wasn't good enough, so I didn't turn in the right one on time, and now the judge is saying, oh, we're not going to count your income, you're non-compliant for income. I haven't been able to take any of the mandated parenting classes because of various issues with the substance treatment that have been available to me, and also the drug testing issue with my creatinine levels. I'll give you one example of issues with substance use treatment. One of the facilities that they sent me to, and there have been 3 now, one of them, they held a treatment group that was supposed to help us, I guess, learn skills or something. I don't really know, because I remember one day I showed up and they were like, our computer system's down, why don't you guys just pay for the class and you can go home. So that was considered treatment. But on that particular, for that particular program, I was actually paying through insurance, and billing them for that would have actually been insurance fraud. So they didn't do it, and they actually just said I didn't show up at all, and then I was marked as non-compliant. So I was unable to take parenting classes because I was non-compliant because of their computer failure. They also have ignored my daughter's own request to see me more and to come home. So they haven't taken my daughter's desires into consideration, and they haven't taken real facts into consideration. They've essentially just stated that I've been reduced to a diagnosis and paperwork. And that is pretty much the status quo in the child welfare system right now. So if people think that the child welfare system is helping families who have these diagnoses access treatment, I'm telling you right now that you're wrong. It's not helping. We need a much better way, and my vote would be to funnel all of the foster care funding into a better social services infrastructure and just get rid of the child welfare system for good.
Thanks for sharing your story, Elizabeth. I'm speechless. I've worked in the criminal justice system for 30 years, and I saw some dysfunction, but that one's pretty amazing. So, Laura,
Thank you.
you're next.
Good afternoon. This audience is well aware that medication-assisted treatment is the standard of care for opioid use disorder, and the research evidence is clear that patients' opportunities for recovery are enhanced by treatment that includes medications. In the only study to date focused on MAT specifically in the child welfare population, parents who received 1 year of MAT were more than twice as likely to retain or regain custody of their children than were those who did not receive it. Yet fewer than 10% of opioid-using clients in the program received MAT. I'm Laura Radel, and I'm the child welfare analyst in an office within HHS that combines research and policy functions and operates essentially as an in-house think tank. I've worked for over 30 years on the interface between the child welfare and substance use treatment systems, helping those agencies recognize that they often serve the same clients and can be more effective working together to help parents achieve stable recovery and ensure that their children thrive. Today we're talking about the disparate perspectives on medication-assisted treatment found among professionals involved in child welfare cases. These perspectives contributed to the challenges in delivering MAT programs to parents involved with the child welfare system and frequently get in the way of families success in overcoming their SUDs and keeping their children safe. I'm going to describe briefly a mixed methods research study that my office conducted last year that documented the relationship between high rates of opioid use disorders in a community and rising foster care populations. I'll discuss 4 key themes that emerged from our interviews with key stakeholders in communities across the nation. And I'll highlight several opportunities to improve how services are delivered. By the time I'm finished, and those other presentations from my colleagues, I hope you'll have an idea to take back to your own community about how to improve the delivery of MAT, the assessment of recovery, and decisions about parents' abilities to care for their children. Our study began with a quantitative analysis of the statistical relationship between substance use and foster care caseloads. Overall, we found that a 10% increase in opioid deaths in a county was associated with a 2.3% increase in reports of maltreatment and a 4.4% increase in the number of children in foster care. But those are just numbers. To better understand what was really going on at the service delivery level, we went behind the numbers and interviewed 188 stakeholders in 11 communities around the nation. We spoke with caseworkers, judges, treatment professionals, and others to better understand their local contexts and perspectives on the opioid crisis and its effects on children and families. I want to give a shout out to Beth Wiegensberg at Mathematica and her colleagues who collected the qualitative data for us. There are a series of research briefs on our website, including one specifically focused on the findings related to MAT. 4 key themes emerged from our interviews related to the challenges in providing MAT to parents involved with the child welfare system. These include the limited availability of appropriate treatment, misunderstandings of MAT among stakeholders, limited interactions between child welfare agencies and treatment providers, and the need for alignment of systems and stakeholders with different perspectives and objectives. I'll speak about each of these in a little more detail. To give you a sense of the range of opinions about MAT that we heard in our interviews, let me briefly share with you several direct quotations from our focus groups. First, the positive perspectives. A treatment provider in Vermont told us that their programs, the longevity of a person staying in recovery is tripled when they get MAT. And the child welfare administrator in Oregon reported that our MAT programs are really well connected to child welfare. Yet we also heard from a number of stakeholders with strongly negative perceptions of MAT. A child welfare caseworker in Tennessee told us that MAT is nothing but legalized drug dealing. Suboxone is the worst thing that's hit us. Similarly, an SUD treatment professional in New Mexico expressed his view that to keep people on MAT is a legal way to keep them addicted. You're masking addiction with another substance. And a child welfare administrator in Oklahoma told us that there are people who are on MAT drugs for years. What are they doing to help these people if you're not weaning them off? I don't understand that. I expect that this range of sentiments may sound familiar to many of you from your work in your own communities. Let me move on to the first challenge we identified in the study, a lack of appropriate treatment. As this audience is well aware, for child welfare population, family-focused treatment services are often necessary to facilitate engagement and retention in treatment and to establish long-term behavioral change. The sites in our study reported very limited availability of family-centered treatment, especially programs incorporating medication, and most pronounced in rural areas. In addition, MAT providers were not oriented typically to child welfare clients. Many did not accept Medicaid for office visits and were not prepared to provide or connect clients with intensive recovery supports, particularly family-related ones. A second challenge we documented is that there's a lot of misunderstanding and stigma associated with MAT. We've discussed that for much of the day. While there were MAT champions in most communities that we visited, there were also those who did not perceive MAT as a legitimate form of therapy. Many were skeptical about its use as the treatment of choice for pregnant women with OUD, and many perceived MAT as the prescription alone and not practiced in their communities as a program that included not only the provision of medications, but embedding medication assistance in a fully realized treatment program. We also heard repeatedly from child welfare caseworkers, judges, and others who didn't understand why medication should be more than a short-term bridge to complete abstinence. They were unconvinced that long-term MAT was an acceptable recovery strategy. A third challenge we identified was related to the limited interaction between child welfare workers and MAT providers. MAT providers generally were not the intensive family-centered treatment programs that some child welfare agencies have developed relationships with over time. They were primarily physicians and clinics with little capacity to deal with families' full range of issues. Many were not interested in collaboration with child welfare, which was viewed to be too time-consuming and was uncompensated by treatment funding streams. Finally, and closely related, we observed the range of stakeholders contributing to child welfare and SUD outcomes were not always rowing in the same direction. They valued different parts of the whole and distrusted one another. And no one seemed to be dealing with the reality that sobriety and child safety were not necessarily equivalent. You can have either without the other. Caseworkers and courts seemed to be fuzzy about how to assess whether a client on MAT was stable and could safely remain or reunite with their children. And without significant feedback between the treatment provider and the child welfare caseworkers, child welfare systems often fell back on using drug tests alone as their measure of recovery. We can do better. There has never been the kind of funding and support for treatment available from federal programs as there is today. And the Center for Medicaid and Medicare Services has taken steps to expand the array of treatment services available through Medicaid. There's technical assistance available on developing and sustaining family-centered programs, and the Family First Prevention Services Act prevents an opportunity for child welfare agencies to become treatment purchasers and pursue evidence-based treatments suited to their clients. We must educate the courts and child welfare professionals about MAT and its benefits. We also need to develop consensus about what it means in practice to incorporate MAT into child welfare plans and plans of safe care required for substance-exposed newborns. We don't declare a child safe just because a client waives a buprenorphine prescription in the vicinity of a caseworker, but nor do we declare a child unsafe simply because a parent fails a single drug test. We need to better define and recognize what safety means in the context of MAT and recovery. Finally, we need to improve the alignment of payment mechanisms and accountability measures to ensure that we're paying for the activities we want and are holding both systems accountable together for the outcomes we seek. If it's a fully functioning family system we want at the end of our involvement with a family, then we need to figure out how to observe and measure progress toward that goal and to incentivize its achievement. So finally, here's a recap of key takeaways on this issue. There are both challenges and opportunities in assuring MAT access for child welfare clients. We need to ensure appropriate family-centered treatment is available that includes medication but is not limited to medication. We need joint metrics for treatment progress and child safety and well-being that are observable, transparent, and agreed upon by all parties. If our agencies are too busy assigning blame to one another and re-engaging to engage and re-engage parents around both their well-being and that of our children, we're not going to get far. Let me close by noting that the products from our study may be found on our website at the link that's shown on the screen. My email is here in case you have questions after the session about this brief or any of our other work. The quantitative part of the study also appeared as a journal article in the Child and Family Services Review last year. So thank you for your time, and I look forward to the discussion.
Thank you so much, Laura. It's really interesting to hear about MAT in this context. Now, we've heard about it with the drug courts and in the criminal justice system, but you can see that it's a really critical issue in the child welfare context as well. So now we're going to hear from Dr. Turpel, who's a treatment provider.
Great.
Teplin, I'm sorry.
Turplin, don't worry about it.
I
have one of
mispronounced
those
his
names
name 3
everyone
times.
mispronounces. I take no offense. Thank you. Thank you for inviting me. As stated, I'm an obstetrician gynecologist. I'm addiction medicine boarded. I really work at those intersections between reproductive and behavioral health. Thank you to the O'Neill Institute for organizing this, because I really think that the child welfare is the critical conversation to be having from a provider and a public health perspective, as I'll show. And I'm really happy to meet you, Laura, but I wanted to call out Nancy and Elizabeth, the two of you. I've learned so much from you over, the years and times that I've known you, and I really am honored to be sitting at the table with you. As mentioned, one part of the opioid crisis, the epidemic of foster care placements, has not received enough attention. There's been a marked increase in the number of foster care admissions. You can see from this slide up there on the right, there are some states where 3 to 5% of all births enter into the foster care system. That means there are so many more births that are child welfare involved. Some of this, just like the original origins of this opioid crisis, could be called iatrogenic, i.e. we've done this to ourselves through a certain misunderstanding of addiction and its treatment and policy. So this is a collection of state policies related to substance use during pregnancy. Note, at the federal level, discrimination is illegal against pregnant people for substance use. However, the weight of state policy is towards the punitive in terms of coerced mandatory reporting, coerced treatment, and et cetera. And whereas, generally speaking, the arc of public policy around addiction is bending away from the punitive. We've heard lots of examples today about, programs that are, less punitive than how things were in the past. For pregnant people who use drugs, the weight of the policy is becoming increasingly punitive. So there's a question, why on the one hand in society are we becoming less punitive about addiction, but more punitive about substance use and pregnancy? So one person who's looked at this is Sarah Roberts, and this is an example of literature looking at alcohol policies. One, you can see the increase in the rate of policies related to alcohol coinciding with the war on drugs. Two, there's no relationship between punitive policies at the state level and less alcohol use on the population level, but the one driver of whether states increased punitive policies related to pregnancy were whether they had other restrictive reproductive health policies. So what's driving this is not alcohol and substance policies, but reproductive health policies, which at their core are really about autonomy and bodily integrity. So, our policies don't align with science, right? Neither from substance prevalence nor risks of substances. From the perspective of the fetus does not know if the substance that the mother is using is legal, illegal, used as directed, not used as directed. Yet we apply that social legal distinction between licit and illicit in the application of policy. Fetuses are far more likely to be exposed to tobacco than alcohol, than illicit, of which overwhelmingly is cannabis. And you can see on the right-hand side, this is sort of like the evidence that we have related to the harms of substance exposures and outcomes that also don't correspond to our application of a child welfare system. I am not advocating for punitive measures for smoking or drinking, but I'm just calling out a misalignment between science and public policy and public practice. At its core, the idea is that there must be a harm associated with, in particular, an illegal substance. And as providers, and I use that term, widely, that includes social workers, nurses, actually includes almost everybody, we do a very bad job talking about risk. We sort of assume that risk equals harm. We don't distinguish between absolute and relative risk, and things that are on the population level, i.e. the likelihood of X, due to exposure Y, is different than what an individual may or may not experience. So our communication of risk actually augments this problem in and of itself. And really, I think what tells the story the best is the career of Halam Hurt, who's emeritus faculty in pediatrics at Penn now, but these are data. She was one of the first people to get a NIDA grant looking at cocaine and outcomes. And her hypothesis was that kids who were exposed in utero to cocaine would have decreased IQ at age 2. And she found no association between IQ at age 2 based upon cocaine exposure. However, she observed that amongst the participants of the study, there was a wide range of IQ, with individuals who were low, individuals in the normal range, and individuals in a high range. And all of these participants were Black, living in extreme poverty in Western Philadelphia. And so this sort of launched her on what is it about those kids with high IQ that are different from the kids with lower normal IQ. And she started doing home visits and operationalizing, literally, the caregiving environment. And that's the data on the right-hand side, looking at learning, stimulation, and other sort of aspects that were associated with increased IQ. And there's only one thing that was not associated with IQ, and that was the physical environment. And that tends to be the only thing that home visitation looks at. So we actually have an evidence base that we do not, again, another example of an evidence base that we do not apply to policy. So when I think about what it is that we do as providers and in public health, we want our care to be both evidence-based and person-centered. And evidence-based means grounded in science. And I think I've showed you that we tend to apply illicit dichotomy to our expectations. We overemphasize illegal substances, minimize legal ones. We also overstate the risks of in utero chemical exposure and grossly minimize the importance of the caregiving environment. And person-centered care is ethical, it's grounded in human rights. It means, the right to determine whether and then when to become pregnant. And I think we need to really be attuned to the unique demands that we place on pregnant and parenting people, and in particular, on their bodies. And so in conclusion, I want to share with you a photograph. This is my mother. And she's pregnant with me. This is like early first trimester. She's smoking a cigarette and she's drinking wine. And I want to share this for a couple of reasons. One, she stopped smoking and she never smoked again. So that attests to the sort of the power of just pregnancy in affecting behavior change. And the second thing is that most of us have used substances to which some people develop addictions. And that actually means that most of us are also substance exposed. So thank you.
Wow, thank you so much, Mishka. That's really interesting. I especially love the picture of your mother. That could have been my household, only could have both parents in the picture. Wow, well, there are some kind of common themes here that we've heard about in earlier panels, and then particularly in this panel, and I certainly was struck by the number and the impact of policies, misinformed policies and dysfunctional systems. And you all are working hard, to do everything you can to address that. But it occurs to me, and maybe it's my criminal justice bias, that a lot of what I'm hearing is that we're not basing our policies and the application of the policies on science, on facts. It's really kind of a misapplication of the human tendency to judge. And we just love to judge other people and to look upon them as being weak. And in systems where things do work well, and I know, Elizabeth, you said, for instance, this never would happen to me in Seattle. What is it that makes for a high-functioning child welfare system, one where the policies are intelligent and fair? I would ask any of you if you have thoughts.
I do want to recognize that we don't have someone from the child welfare system here, and I think that's important to recognize. And, you know, child welfare does not remove children for substance use alone. I have never been to a community in which that happened. They are looking for allegations of abuse and neglect and different forms of abuse and neglect. Removal is the last resort. And is that applied uniformly, worker to worker, county to county, state to state? No. But either as criminal justice, either as health care. So I think we need to, you know, kind of stand back just for a minute. There are many children who are abused and neglected in our country. And we can't call for the elimination of the protections that we have put in place for children that have experienced abuse or neglect. So what makes a well-functioning child welfare system? I think there's a lot that goes into just that. I can speak to what makes a well-functioning substance abuse and child welfare informed system. And I think we heard from some of them this morning from Michael in Maricopa County that has worked with Dr. Turplin. They have created and are implementing plans of safe care before the baby is born, eliminating placement whenever possible. Is it eliminating all placements? No, nor should it, because there are some risk and neglect kinds of factors, immediate safety factors that do need to be tended to. So there are communities that many of the things that I showed about the different kinds of practice and the supports that are being put in place, recovery supports that are readily available in which that's working.
So part of what you're saying is be prepared ahead of time. You know, have other solutions in place, tested solutions. We know it works, we know it's accessible. Have that all set up so that you can keep families together when it's appropriate.
When it's appropriate.
Appropriate to do so. Well, and you say that, you mentioned that removal is a last remedy of last resort. There is some public perception, certainly in the media, that if a person is pregnant or is parenting and misuses drugs, that's child abuse. That kid cannot protect himself or herself. You are abusing your child. What is your experience with that? Mishka, I'd like to hear from you about it in the medical context. What's your experience with that, and how should we address it?
So are you asking the question, like, are pregnant or parenting people who use drugs unfit to parent?
Right.
If that's the question, I would say the short answer is no. That, and I think we want to take a step back and think about what substance use is and also what parenting is. What are the core components of ensuring, you know, child safety and welfare? And I think I completely, that the purpose of child welfare and its historical purpose is to ensure safety. And that remains incredibly important because there are certainly children who are being abused and neglected. But that safety barrier can be applied in ways that actually end up harming children and harming mothers and harming families as well. And I think there's not an individualized, always approach. This can be a one-size-fits-all sort of system that you find yourself into. So what do children need? I would say people need stability, love, and no violence. And those three are completely possible in, a parent who uses drugs, and those things can be caused from child removal. That can lead to instability and placed into foster care environments in which it's actually less safe, and where harm can and does happen. So I don't think categorically using drugs disqualifies you from a parent. But what we see applied in this system are sort of narratives of deserving versus undeserving motherhood, and certain categories of people, i.e. people who use drugs, people who are not white, people who are poor, being more caught up, and that being enforced through lots of things in society, but inclusive of child welfare sometimes.
Can I give an answer to that as well?
Certainly.
So I wanted to just briefly say that pregnancy can be a great motivator for recovery. It was certainly my biggest motivator. I started methadone treatment when I learned that I was pregnant with my elder daughter, but it's not an actual cure for addiction. So if we're recognizing that addiction is a chronic relapsing brain disease, then we can't just say that pregnancy is the cure. And if pregnancy is somehow a cure-all for chronic relapsing diseases, then we should prescribe it more often. So I wanted to say that. And I also just briefly, to your earlier question, also want to mention that the majority of child welfare cases that we know for a fact, about 75% of them are not abuse cases, but neglect cases, which typically is the result of poverty. So lack of childcare, lack of appropriate clothing, maybe lack of housing or access to medical care. And these, for the vast majority of them, are things that could be remedied through just like more money. Like, just put it plainly, just like give these people some money. Or if you don't want to give them money for whatever reason, give them some social support. They don't actually need child services interventions to fix those problems. So that's where that comes from. When I say that we need to funnel the foster care funding to better social supports, it would fix the need for the vast majority of the cases that we have today.
As Laura mentioned, that's certainly the possibility and the hope behind Families First, that that will move into preventing child placement. But I just want to add some numbers to the discussion, because I think it's important that 3 kids in every elementary school classroom go home to a parent that's alcoholic or needs treatment to illicit drug abuse. We don't investigate anything like that kind of number. We don't remove anything like that kind of number. Of the 5 million reports, about 3 million investigations, 250,000 children are placed in protective custody. Of the about 400,000 infants that are born with prenatal substance exposure, about 50,000 infants are placed in out-of-home care. So I just want to paint that picture of, we have this huge number of children who are affected by parental substance use, and a very small number in which the intervention is in the child welfare system. And I believe that Congress and policymakers are all recognizing that that's not the place where most kids belong if they can be protected in their home, from many of the things that you spoke to, Elizabeth, in terms of the kinds of services that are needed and the kinds of supports that are needed for families.
Well, and I think we all recognize, too, that every jurisdiction has its own child welfare system, and some of them are functioning extremely well and really do right by families, and some, apparently you ran into one of them, Elizabeth, some just could use some help, I think, a little bit of advice.
And to your earlier question about whether substance use is child abuse, I mean, legally, it depends on how the state defines it.
Exactly.
And the state determines what is child abuse, certainly for the court's purposes. And there are a very wide range of how the states do that in law, some starker than others.
Right.
And it's about half. About half of the states have state statutes in which prenatal substance exposure are grounds to substantiate abuse or neglect, which doesn't mean that that would equate to removal, but again, worker to worker, county to county, state to state, on how that is actually applied.
And I think another issue here is that the child welfare system was always designed as a system to deal with acute problems. It's designed as a short-term, supposedly, intervention for an in and out deal with a crisis. And that's very different than the long-term chronic nature of substance use and recovery. And there's just a fundamental mismatch in those perspectives.
Yeah. I think we're going to take a few questions from the audience now, and we have folks on this side of the room, not the other.
Hello.
Hi.
My name is Fallon Speaker. I'm the director of the Family Law Clinic at the University of Richmond. I don't actually have a specific question. I just would like to offer a response in regards to one of the comments that was made. I have worked in the child welfare system now for 6 years, representing parents who are accused of abuse and neglect in New York City, specifically in the South Bronx, via the Bronx Defenders. In my time in representing parents there, I would say that a large portion of the cases that I received dealt with parents who were accused of abuse and neglect because they had used substances while they were pregnant. Meaning that they gave birth to a child and either they tested positive for some substance or the child tested positive for some substance. Up until recently, maybe in the past couple of years, those cases were always removal cases. And in the past couple of years, the reason why those cases haven't been removal cases is not because all of a sudden judges are saying no longer is this neglect or abuse, but because they've said, okay, we don't have to necessarily remove. What we're going to do is place you in a prison-like setting. And that's also known as the inpatient drug treatment program. And so they would place my clients into these inpatient drug treatment programs where they could have no contact with the outside world. They were on a zero-tolerance drug use policy, meaning that if they used any substance or were perceived to have used any substance, that their child could be removed from them in the program. Oftentimes, they were placed into these programs with people who had severe mental illnesses. They were not always given the proper level of treatment. Oftentimes, the recovery and the treatment method was a one-size-fit-all sort of treatment method. If they failed to complete these programs, which oftentimes required them to stay there for anywhere between 9 to 18 months, and oftentimes did not allow them to bring any older children. And so say they gave birth to one child and they had 2 children who were above the age of 5 or above the age of 9, I think, which is the oldest program in New York City, then they were not allowed to bring those children into care, and those children had to go into foster care. In those cases, the removals were always because the parent had a substance use problem, as alleged by the agency. And then I've also had the ability to be able to practice this law now in 3 different states, North Carolina, Virginia, and New York. And I've also been able to observe different family courts across the country. It is inaccurate, completely inaccurate to say that removals don't happen solely because of substance abuse. They actually do. It varies among jurisdictions, just like Elizabeth stated earlier. There is no one-size-fits-all as it relates to the child welfare system. What we have to account for is racism, classism, poverty, rural versus urban areas. Those are all things that go into effect when you're talking about the jurisdiction, the judges, the CPS agency, and the way in which they handle families. And I do mean handle families because that's exactly what they do. I think the other thing that I really wanted to talk about is that the way in which, because of the federal guidelines and the federal timetables, many families are unable to reunite, and that leads to termination of parental rights, as in Elizabeth's case. This is a very common thread. I work with a whole lot of prisoner rights organizations and organizations that are working to make sure that there are alternatives to incarceration for many parents who are involved in the child welfare system for this reason. Termination of parental rights can happen in some jurisdictions along the federal guidelines of 15 to 22 months, but in many jurisdictions, such as, for example, Virginia, they're doing it at 12 months. In Florida, oftentimes at 6 months, sometimes at 60 days. And so I think this is an important call to action for us to open up our minds a little bit and just know that if there are 40,000 children who are being put into the system, even if the larger number is 400,000, that is 40,000 children too many. If there are, I don't know, 50,000 children out of 3 million children who are being terminated per year, that's 50,000 children too many. And in many of these jurisdictions, all it takes is one termination or one abuse finding or one neglect finding to fast track that path for parents who are involved in the child welfare system. So I believe this is a great place to open up this conversation and think about how this affects people in different jurisdictions. Thank you.
Thank you very much. Does anybody want to comment?
I think I should clarify that states don't have state statutes to remove for grounds of substance use alone. The allegations are abuse or neglect and various forms of abuse or neglect. So I'm not sure New York State statute on parental substance use and how those allegations would be filed, or what grounds they would have for removal, unless there were also substantiated findings of abuse or neglect.
But remember, my substantiated finding of neglect was the mother neglected the minor children by neglecting the minor children. So that's enough for a judge to say to take away a child.
Wow. Next.
Hi, my name is Lisa Sangoy. I'm with an organization called Movement for Family Power. We support the organizing and movement building of communities to fight back against the child welfare and foster care system. So I want to, hone in on a very important point that Elizabeth made, which is that drug use and substance use disorder is very distinct from whether you pose a risk of harm to your child such that you are an unfit parent. Those are two totally different things that get conflated with each other all the time. So I was at the Legacy Memorial in Alabama. Who knows about this memorial? Memorial to lynching and slavery. And one of the things that really caught my attention there was that it wasn't just law and policy and people who had plantations that upheld the practice of enslavement. It was a whole medical and social science community that created the science to uphold the practice. And when we look at the medical literature on crack use during pregnancy and the crack baby scare and all of those terrors, it harkens back to that science. When we look at the current literature right now on the effects of drug use on parenting, literature that is extremely low quality, literature that my organization has been working on a very comprehensive lit review to really poke holes in this literature, it harkens back to that science. And I think we need to remember this. People have met, and now I'm going to skip to another point. People have talked about, well, the purpose of the child welfare system is child protection. Let's remember the origins of the child welfare system. Does anyone know what the first effort was to save children from their abusive parents? Yep, so the child welfare system is responsible for an enormous amount of violence against Indigenous families, absolutely. The very first effort at this were the orphan trains in New York City, where white men who were worried about Irish and Italian immigrant children who were, they feared they were a menace to society, went into homes, removed children en masse, and moved them out to become indentured and forced labor on farms all over the country. That's the origin of the child welfare system. It's not something I'm making up. This is all fact. So the child welfare system has always played a very critical role in the socialization, assimilation, genocide of people who our country did not want to deal with. It is not a coincidence that everyone in the system is poor and black and brown. It's not. The last thing I will say, and then I'll sit down, family treatment courts. We keep talking about family treatment courts. Let's think about this. Before you are accepted in a family treatment court, you must admit that, yes, I have committed abuse and neglect against my child. How inhumane is that? Someone talked about leukemia earlier today. Would we force parents who have leukemia to admit to having abused and neglected their children? Absolutely not. Okay, I'll sit down now. Thank you.
Thank you very much. Okay, we'll take your question.
Hi, my name is Casey. My question for the panel is, how can we resolve the dissonance between a federal legal system that says it is not allowed to discriminate against mothers who are on medicated assisted treatment and a legal practice that actually does discriminate against those mothers? And specifically, what kind of role can social workers play in bridging that gap, if a role at all?
Any of the panelists want to respond to that?
I think if social workers become educated about the efficacy of medication-assisted treatment, that it really does, in fact, work, and that it doesn't need to be just a short-term or detox aid, which some social workers will support it for that reason, but not for long-term use, and then go and actually advocate for the parents. That would be very helpful, because in that courtroom, as a parent, what you say doesn't really matter. That's been my experience anyway. The judge, if what I say is, even if it's backed by facts or just the plain truth, whether I have a document of it or not, but it is the truth, if the social worker or the state attorney says otherwise, then I'm wrong and they're right. And that's pretty much how it's regarded. So if these social workers can become educated and advocate on behalf of the parents that medication-assisted treatment is effective and helpful and should be implemented when they want it to be, when the parent wants to use it, and when appropriate, then that would be very, very helpful.
And I think it's education beyond just the social workers. I mean, I think we need to make sure that judges and the attorneys and the whole range of folks involved understand medication-assisted treatment, understand addiction more generally, and understand child welfare. And, you know, I think when they don't know those things, they either resort to gut feelings that may have nothing to do with the science, or they, in child welfare especially, they resort to fear. And when in doubt, they, you know, fear a risk that a child will be hurt or die, and kind of instinctually try to not have that happen, and they overblow that fear, and it gets out of hand.
I will mention 2 resources that are available. On the National Center on Substance Abuse and Child Welfare, there are 3 online courses that are free to take, one for social workers, one for substance abuse treatment professionals, and one for judges and attorneys. And they were recently just updated to include issues of medication-assisted treatment and opioid use disorder. So if you're in a community and your social workers need that information, that is available to them. The National Center on Substance Abuse and Child Welfare also has a project underway with the Office of Civil Rights in the Department of Health and Human Services to do exactly what you're saying in terms of education to attorneys and judges about the legal rights of persons with opioid use disorders and other substances.
Thank you very much.
I wanted to ask specifically, you said you had a lot of experience with a number of different social workers. Going off of that, how experienced did you find, or knowledgeable did you find them about Medicaid-assisted treatment?
In terms of like the social workers I've dealt with in my case, like that have been turned over like 4 times, they don't generally know very much about it, it seems. They haven't been explicitly against it. There was one social worker, my husband has been on long-term methadone, who for some reason seemed to believe that some doctor had said that he should taper off methadone, which never happened. So I don't know if she got his case confused or just that was her general belief. That was kind of the only negative thing that they said. So that's been one positive aspect in a really negative case, is that the caseworkers haven't been against the medication, but they don't really know much about it either. I know that like my caseworker was reading off like my drug test results when I was on buprenorphine, and it was prescribed, and she was like, couldn't pronounce it, and then my lawyer had to have her like explicitly like remind her like that's what's supposed to be in her urine, right? Because it's prescribed her, and she's like, oh, right, yes. So it's not really a positive.
So we kind of return to the question that you raised, Laura. How do we improve decision-making in the whole child welfare system? And obviously, education is a huge, huge challenge.
I think we need to more systematize how we understand recovery, observe recovery, that it's not, you know, every caseworker's and judge's personal opinion, that we, you know, have metrics and can see and you know, have more to it than that, and that we, you know, again, make sure that everybody's on the same page.
Okay, we only have oh, sorry.
Just, I mean, there's an inherent inequity within the system, and Lisa made a very good case for abolition of child welfare. I would say, regardless of the institution of child welfare, there are needs that families and new mothers have. And because we apply access to those can come through the child welfare system and that are targeted to a specific population of people, let's say with use disorder, that's going to continue to, that compounds, a type of discrimination. The only way I see around this is by universalizing social work assessment for all birth mothers, so that everyone gets some kind of an assessment as to what their needs are, both, material, supportive, and et cetera, and receive the care so that they can parent, to their greatest ability, and that those kids can, develop to achieve their full potential. But until we kind of take it out of the lane of substance use, misuse, and addiction, being attentive to the important distinctions between those categories, it's going to keep falling back into inequities.
Thank you. Okay, question over here. It's another medical person, is that right?
Hi, yeah, Dr. Joey Nichols. So in my work with the Baltimore County Health Department, this is a great segue, right? Because I was originally brought on to do MAT in the county jail, and that keeps us very busy. Oh, by the way, we're the Department of Health and Human Services here, and we have incredible demand in the place where I work, that I support, to educate all kinds of staff who deal with the child welfare system and all throughout the agency about stigma and MAT. And it's been really kind of wonderful. And what's interesting, we had one training, 200 spots, oversubscribed, like 600 people wanted to come to this 200, so now we're doing a road show. And I want to thank a lot of people in this audience because you put your slides online and I've stolen slides from you. So I know that my training is good because y'all wrote it. And I'm very funny, obviously, so people come and they have a great time and they learn about this. And so I really want to, the bigger picture here is it's helpful when we recognize health and then human services, right, like together. And a lot of places they have that. And anyone know, by any chance, maybe some of you do, what's the second, I'm always about the money, right? So what's the second biggest Health and Human Services, U.S. Health and Human Services agency, after CMS, obviously? Anybody know?
Social Security?
Different agency, so that doesn't count. Good point. I mean, they have bonkers money, right? No, $1.3 trillion in CMS, sure, that's crazy money. $53 billion is the next biggest, and it's the Administration for Children and Families. They have a ton of money. All the TANF money goes through them. Right? So, so what could we do, I wonder, on the ground level and all the places you go to try to bring together the people from ACF with the other HHS agencies, particularly Medicaid, which is, Misha probably has a number off the top of his head, something like half of all pregnancies and births in the United States, Medicaid is it's higher, right? So it's a lot, right? So there's a missed opportunity here just to get people thinking, sure, Medicaid's gonna pay for the baby to be delivered, they're gonna wind up on ACF's balance sheet for a while and kick right back to Medicaid. So there's a lot of missed opportunity, I think, for collaboration. And we have a small microcosm of that in Baltimore County. My question, actually, I do have one for the panel is, have you seen any other examples of this, of the healthcare folks kind of talking to the social services folks and working productively, and what could we do to do more of that?
Our office sponsored a forum just a couple of weeks ago that was bringing together a range of folks from around the country. There are probably about 200 or 300 people there around the human services aspects of substance use issues. And it was a great day. I think a lot of the materials are online, but it was a great conversation we had a lot of health folks as well as human services folks, but to talk about how the issue kind of bubbles up, not only in the child welfare system, although that was representative, but also in employment programs, in the TANF program, in child support, a range of human services programs that all see it but don't always recognize the issues.
Go on that website. I'm sure there's some slides ripe for the picking. Yes.
Hi, my name is Jeanette Jeter. I'm probably the only child welfare social worker in the room. And I'm not defending the system. I think that there's definitely a need for reform. I can speak only about Pennsylvania. But we're stuck in the system too. So we as caseworkers on the ground level have no input on policy. We have to follow the directives of supervisors, of admins who haven't been in the field in decades. And so it's not so easy as just to advocate for your client because you're working for the government. So, you lose your job or you advocate for your client are sort of the options that you have. And if you want to do the work for the children, and that's what I think is missing in the system, is that it's fragmented and that it's not child-focused the way it should be, and it's punitive and it's horrible history. But I think that wish people would stop like blaming social workers all the time, because we're stuck in the system too a lot of the times. Every state and every jurisdiction is different for. I know why, because states opt out, but it's just weird. Like the situations that people have mentioned wouldn't have happened in my jurisdiction because they have great attorneys or great enough attorneys or judges that get called out for misconduct and are no longer practicing in that court. So there are ways that the system can be held accountable because it's just people. It's people that are elected. It's your judges that you elect. It's your state legislators that are making these policies, on a local level, and it's not just the social workers. That's all I want to say.
Thank you. Anybody want to comment?
I'd comment on Baltimore, the question about Baltimore and where is it working. Baltimore County actually applied for a 4E waiver at least 20 years ago, something like that, in order to shift their funding, and it was going to be specific to parents with substance use disorders. They actually pulled out of it and they didn't implement it. The state that did go forward with a similar kind of model is Illinois. And Illinois, since that time, has had 3 or 4 renewals of their waiver that they're actually spending Title 4E monies, where that one of those really big pots within ACYF for recovery coaches and making sure that parents get access to treatment in that way. So it is working in many places. Illinois is one of those sites that's using recovery coaches in some good ways. Another place around that same time that Baltimore wrote that waiver and then decided not to implement was Sacramento County, and they recognized that across all of their health and human services, every worker needed to have information about addiction treatment and recovery. And they set upon about a decade of doing what they sort of referred to as remedial education, because the professions, the disciplines that were working in their HHS department did not have the pre-service education to work with families that were affected by substance, we called it substance abuse then, but by substance use disorders. So they had a very long track record. Now for infants in Sacramento County that are identified at birth with prenatal substance exposure, it's most rare that the baby is removed. They participate in an early intervention family drug court. They get in-home supportive services with a lot of wraparound to make sure that parents can get to treatment and that the family's needs are being met. So there are places of hope. Another one that I would talk about is Tompkins County in New York. That has had a very big shift in the way that they work with families, and in particular in their family treatment court. When we say family-centered in the family treatment court, they really operationalize that to say that parents have a voice at the table, that the needs of parents and children and the extended family are brought together to make sure that that's happening. So there are places where that is definitely in play, and there is not only just hope that that can happen, but there are lessons from those sites in order to help other jurisdictions move forward.
Thank you very much, Nancy. 2 questions left. Yes?
Hi, my name is Abena Subira McCall. I'm an assistant professor at the School of Social Work at the University of Texas at Austin. And more of a comment than a question, but I just wanted to put on the floor that one of the realities that we haven't talked about really is that people are trying to run away from culpability, that agencies, that judges, that social workers are often the people who end up being held accountable when things go wrong, and that fear motivates a fair amount of our inefficiencies in policies, the things that don't make sense. And it's because, right, we can think about Willie Horton, right? So when somebody does something wrong on these programs, we haven't developed an understanding that it's not going to go always exactly right, and that we don't have a way of developing programs and interventions that are compassionate, that are realistic, that are based in the realities of people's lives, and because there is that risk is a part of all of this. A lot of people are really disincentivized to be engaged and or to do anything different. right? So it's only when you sort of move away from the status quo that you're punished for the outcome. And I think that that's just worth putting on the table.
It's a very good point. Thank you so much. After all, it's just people, there's no foolproof system.
Hi, I'm Sally Friedman, an attorney at the Legal Action Center. And because the woman who was over on the other side before had said, how can, if it's, against the law to deny people access to MAT in child welfare settings, how come it happens? And I just wanted to add that, in addition to social workers and maybe judges not understanding the nature of addiction or effective treatment for it, the lawyers who represent the parents don't either in much of the cases. And so, and it is extraordinarily frustrating because people do have rights, but there's really no way for them to enforce them if there's no one going to bat for them. And so I just wanted to highlight that people can file complaints with the Department of Justice and the Office of Civil Rights. It's a simple online complaint. They can contact the Legal Action Center and we will do it for them. And that is not going to solve this problem on a systemic basis, but we have seen the OCR and DOJ intervene, and they can, right now I think they're doing more of an educational approach, but it's a step in the right direction, and we're also trying to educate the bar about this issue.
And Sally, thank you for all the work you've done on this issue, because there's some great things that have been written that are very helpful for us as we try and make sure that judges and attorneys know what the rights are for parents.
And Nancy, you told me this a number of years ago that I have always remembered because it really struck me, is that one of the things that makes a real difference in a case and how quickly folks get into treatment and whether they have a real chance along the timelines is whether the parents' attorneys, whether they advise the client deny until you can't anymore, or whether they say, if you've got an issue, get into treatment today and start treatment early, and that really makes a difference, and it's around the advice of the attorneys and their strategy in going into a maltreatment case.
And I also just want to add that, unfortunately, it also tends to be the white parents that even have access to MAT in the first instance. Mm-hmm. And with over 80% of the people in America who have access to methadone and buprenorphine being white, and those are the people who contact our office for help. And so I think, of course, the much even bigger problem is the racial disparity in access to treatment in the first instance.
That's a really good point. Thank you, Sally. Well, I'm just kind of blown away by how much I personally learned from this panel this afternoon. And I hope you all learned an awful lot, too. And I think we've seen a lot of the challenges in the systems, and we've kind of learned about some of the things that don't work so well. But also we did hear a lot about things that do work and systems that are functioning well, and got some good resources to turn to help fix the things that haven't yet been fixed. So I want to thank you all, and Elizabeth, especially for sharing your personal story. I know that's not easy to do, but thanks to all of our panelists, and thanks to you.
Thanks, everyone. This was our final panel, and so I worked in government for the city of Seattle and on the executive branch of the president for a total of 16 years. And now I'm in this academic institution where the best part about it is that it causes me, and I think my colleagues, and hopefully everyone today, when you're in an academic institution, you get to hear different thoughts, different ideas that may challenge your preconceived notions about issues that you're facing, about how your policies may affect people, and cause us to rethink these traditional approaches that we've perhaps taken. And I am having, it's a great opportunity for me personally to step back and kind of think about when you're in a government position, when you're in a government role, you're basically just addressing incoming constantly, and you don't really have a chance to sit back and read journal articles and talk to people who might have a different opinion than perhaps your political leadership may be directing you, so that you can take this information and then hopefully implement it in the future. So what I want to do now is just close out by talking about a few of the themes, next steps, and then Shelley will come up with a few closing remarks as well. I think a few of the themes that I took away from today were, that this is about resources and will, and resources come in different ways. Resources are not always financial. Resources can be kind of personal resources. And I also liked the thought of we are the epicenter of the solution when we think about Huntington, and because people are thinking about this problem in such dire ways, that also many people in this room are the epicenter of the solution when you go back to your communities. It's about prioritizing saving lives and leadership. So one of the best parts about working in government is that when you're in a position in the executive branch, you can bring people together who come from different perspectives, who may come at it, the idea of diversion, it's a legal term. And it's the first time that I talked to medical folks about what diversion meant, it's a totally different way of thinking about it. Diversion is not, it's a life-saving mechanism. It's a resourceful mechanism. It's not an activity that may or may not be legal. So we also talked today about drug courts and the importance of sanctions and not applying sanctions when that's contrary to what we know about addiction as a chronic relapsing condition. So at the beginning of the day, we talked about a couple questions to kind of guide the conversation. What changes need to occur? I think we've addressed a lot of questions, brought up a lot of questions throughout the day. Are these changes happening? Certainly some are, certainly not enough. And what is it going to take to bring them about? So what we were hoping to do with this project that we have at Georgetown is to begin to look at those questions. We've worked on this report. Shelley did a lot of the heavy lifting on the report, so kudos to her for the work she did on that. And we were informed by lots and lots of conversations with many people in this room. And then what we want to do for next steps is take that report and make it actionable in communities. So you'll be hearing from us in the future about other opportunities, kind of taking these in bunches. What are the reforms that are recommended, and how can we implement those on the federal level and the state level, and then in local communities? We will be sending an email out asking folks to sign up for a listserv, because as hopefully you found out from today, there are so many people who you can call on to learn from and build community around these issues. So what we want to do is have this listserv that will be a moderated listserv where we can kind of help to, not as a technical assistance, but again, providing people with connections and information and resources that they might find useful. So we'll be sending that out along with, so you can sign up for the listserv and send it out to others who might be interested. We'll have the slides available also. This event today has been webcast so that you can also watch it later, because I'm sure you're going to want to, or send it to others. We'll be dividing it up by panels so that there might be someone who you know might have an interest in a particular topic that you could send it to. So, we really want this to be the beginning of a discussion, not the end, and we will be following up with each one of you. And Shelley, if you want to come up and talk about some last thoughts. Thank you very much, everyone.
Thanks, Regina. And, I'll just say a few words that every person that signed up for this convening and came today and is listening at home, you all are champions in your communities. I mean, I think there are probably every person in this room could have gotten up here and talked about the work that you're doing in the community, your personal experience, how you're turning that into a shift that is sorely needed. And so I want to encourage the folks that are here and that are, listening we provided a list of contact information to reach out to your colleagues that are here because we don't need to reinvent the wheel in each community. There are lessons to be learned from many different areas, and we should all kind of like be in this together. And, you know, the other thing I just was thinking as I was sitting here and listening, this thing is being built on the shoulders of movements that have been in process for a long time. Healthcare access, racial justice, criminal justice reform, mental health advocacy. And when we talk about silos of systems, I want to encourage us all not to think in silos of movements, that we all want to work together to build a compassionate society. And how can we do that and use each other as a resource to do the hard work necessary? So did you mention the... Okay. All right. Wanted to open up for a few minutes at the end here. If anyone had any comments or additional things that you wanted to make an observation about or talk about with the group that's here. Yeah. Are the microphones gone?
So my name is Jan Brown. So my name is Jan Brown. I'm a woman in long-term recovery, which for me means that I haven't used drugs or alcohol for the past 32 years. And for me, one of the things that I've heard throughout the afternoon and the morning as well is a lot of talk about stigma. And and that language matters. And I would like us to, rather than saying medication-assisted treatment, which I think is further stigmatizing, to use the term or the terms medication for the treatment of opioid use disorder or medication for these purposes. We don't say somebody is doing medication or participating in medication-assisted treatment for other illnesses. So I think it's something that we can do. I think it's going to take time for us to really make that adjustment, but in many circles that I travel in, just the notion of medication-assisted treatment is quite stigmatizing. Thank you.
Other closing thoughts? I mean, the other kind of question to pose to this group is, and I, like Regina, came from some years of working in government, and then before that in advocacy, where you're always kind of putting out a fire or the crisis of the day. And it's, to be in an academic environment where you have the time to kind of research and think and talk to people and convene, that's the other thing I've been thinking of, is how do we use the platform of Georgetown and this tremendous kind of resource of, medical school, public policy school, social work, the law center, and the fact that we're here in DC to really advance some major shifts. And so interested in any other thoughts about that as we kind of go into this next phase of not only just implementing some of the things we've identified in the report, but continue to develop this project on addiction and public policy. Well, feel free to reach out if you have thoughts or want to meet or chat. And I thank everybody again for joining us, and enjoy the rest of the day. Thanks.